Good morning. It is now 10 o'clock on Monday, the 11th of September 2023. And I would like to welcome members from across the county as well as our guests to this meeting of Staffordshire's Health and Care Overview and Scrutiny Committee. Today we've got a very focused agenda which I think either was by accident or a demonstration of actually good agenda planning. So welcome everyone. I am your Chair, County Councillor Jeremy Pert. I would just like to make some introductory comments just to start off before we move on to the agenda. So members will be aware that the flu vaccine based on age group is available to residents from the age of 75 from today, and then we'll roll through into lower ages as we go. I don't think we need to do anything in terms of mentioning to our residents that that's the case. They will be contacted by those people who are administering the vaccine. It's rather hot in here today, and it's probably a reflection of the environment and temperature outside. So if members want to take off their coats and ladies the equivalent, then please feel free to do so. But during this hot weather, if we can remind people to drink as much water and clear fluids as possible, so I should say non-alcoholic actually, rather than just clear fluids. If people can drink as much as possible, that's a good thing to do. I'm reminded that the County Council is about to launch its tender, retender exercise for supported living, and that will be something that will be happening over the next 6 to 9 months, and we will report further on that. I don't think we need to look at the process. It's a standard tender process. I think we should just leave the County Council to run that, and then just look at the impact later on in the process based on individuals, but not wanting to prejudge what the outcome is going to be. I think we should just note that and look at that later on as we go. We talked a couple of months ago about access to defibrillators, particularly in the moorlands, and we've recently held a meeting with West Midlands Ambulance Service, who were able to confirm to me that the process for accessing defibrillators by both 999 and 111 is exactly the same across the whole of the county and across the whole of their 14 affiliated authorities, and that there is access with details based on postcode, which I know in rural areas is rather large, but also based on technology like grid references and what 3 words, and I think that satisfied the questions that were being raised originally from the moorlands. In addition, there was a question about rurality and the access to ambulances across the whole of Staffordshire, and we circulated the CAT 2 figures recently to all members. However, I would like to recommend, and we'll pick this up in work programme planning, I would like to recommend that we invite the West Midlands Ambulance Service in to an additional scrutiny meeting, probably in November, in terms of diary planning, so that we can review their performance, because there was certainly issues that they were raising in the discussion that I think committee would be wise to be alive to, and maybe want to scrutinise the work that is going on within the West Midlands Ambulance Service. And maybe you might want to read into my comments when we come to look at work programme planning. So those were my introductory comments. Can I remind members that today's meeting is being recorded? For those people who want to watch back today's session, the recording can be found on the County Council's website. The meeting is also being beamed live for people to be involved, and will cut off 20 seconds after the equipment has stopped. All voting committee members are in person, and there is a variety of guests who are both in person, so thank you for making the effort. I really appreciate seeing people. I know Teams is good, but sometimes it is better just to have some of our guests in actual attendance, so thank you, and also welcome to our guests who are online. And if I turn around, I can see who they are, and that's great. So, on to today's agenda. Declarations. Sorry, I did this last time, didn't I? Apologies.
Good morning, Chairman. I've received apologies from Councillors Cox, Hewitt, Holton, Bain, Lung and Councillor Williams, with Councillor Stanton attending as a substitute.
Welcome. We've seen you before, so thank you, Zach. They are noted. Declarations of interest. Ladies first.
Thank you very much, Chairman. Good morning, everyone. I'm Partner Governor on the Midland Partnership Foundation Trust. Thank you.
Duly noted. Thanks, Anne. Bernard.
Excuse me. Good morning. I'm the local authority appointed governor at UHDB.
Duly noted. Any other declarations? That's fine. Thank you. So we have two sets of minutes within the packs. The first set of minutes relates to the meeting on the 24th of July. Are we happy that they are a true and accurate record? Okay, thank you. I think that was just about unanimous, so that's fine. Let's move on from there. Just one comment in passing. We will, in next month's agenda, put in numbered actions so that we can follow them as part of the log. I know we keep asking about this. It will happen next month, even if I have to write them myself. That's... Okay, yeah, you know, I'm going to have to work hard on my education, obviously. So moving on to the minutes for the 31st of July, just can we make two changes on page 10? They're very minor. It's the paragraph that starts alongside a third of the way down. I think the last bit should say these strengths and areas for development were shared with the committee. And I think on the next paragraph it's evidence rather than evident. Well, it's evident to me that it's evidence. Are we happy otherwise? Sorry, Anne.
Sorry, I wasn't at that meeting and my apologies wasn't given on the meeting. Thank you.
I remember giving your apologies, so we will add them to that. Thank you. Any other comments from anyone who was there? No? Okay, are we happy with them as they stand? Yes, yeah. Thank you. Let's... This Thursday. Just one comment in passing, which is I think the Health and Wellbeing Board's Right Care, Right Place meeting is coming up shortly, and we will just put that to send a note round later on today as to when it is. I have a feeling it might be this Thursday, just for members' awareness. So I'm behind myself again last Thursday, but you can pick up the recording online from last Thursday's Health and Wellbeing meeting. So that broadly brings us on to item number 4, Good Mental Health in Staffordshire Strategy, 2023 to 2028 Draft Action Plan. Can we align 10 minutes for the presentation and then move into questions? Is that fine? And who's leading on this? Is that you, Julia? Good morning, Julia.
Good morning to you, Chairman. Yes, if I can do a very brief introduction and then hand over to Jan, who's done with all her colleagues, both NHS and County Council, a lot of work in preparing this. So if I may, just a very brief introduction. This is a joint strategy with the NHS and ourselves. And it was approved by the ICB and the County Council in March of this year. Following that, a lot of detailed work has been undertaken to compile this draft action plan. As with all these strategies, the devil is in the detail, and I appreciate a lot of hard work has gone into this. Within the action plan, I think there are one or two metrics still to be developed, but there are a lot of what I would call pretty smart targets, which is important. Mental health is not only important to us all, but is a key work stream for the Health and Wellbeing Board, and the delivery of the strategy will be overseen by the Health and Wellbeing Board. So I will hand over at this point, but obviously any comments, recommendations from the committee will be most welcome. Thank you very much, Chairman.
Thank you, Julia. So are we with Jan? Sorry, I'm looking in the wrong place. It's screens and people and more people. Sorry, that was my fault, Jan.
Thank you, Julia. Yes, I'm Jan Cartman-Frost, Senior Commissioner Manager in Health and Care. I'm joined on Teams by Becky Murphy from Children's Services and Sarah Tunnicliffe from Public Health, and Nicola Bromwich is here from the ICB. So all the main leads in developing the strategy and the action plan are present today if there's any specific questions. So as Julia said, the joint strategy was approved in March by both the Council and the ICB. And then since then, we've been working collaboratively to pull together a draft action plan. The action plan, the challenge, similarly to the strategy, is the vast amount of work that is happening around mental health and well-being. And the challenge was not to try and recreate that, because that would be enormous. So what we've worked on is identifying the most kind of key actions that we think support the outcomes of the strategy, and also enable us to monitor that, monitor progress and report that through to the Health and Wellbeing Board, who will be monitoring delivery of the strategy. So there will be other actions out there taking place, certainly in the ICB, for things like the community mental health transformation. So these are not exhaustive. This is kind of representative to support the strategy. There are some new actions in there which have come about from feedback through engagement, or areas where we believe we could perhaps do more work together. So there's one or two areas of there in the action plan as well. Again, with the strategy, while it was focused on adults, we did recognise the importance of supporting young people's mental health. So when they came to adulthood, their mental health was improved. And so there are some actions we've included that colleagues in the ICB and Children and Family Services are doing around young people's mental health. The action plan we're proposing is for the whole life of the strategy. Some of the actions we've already identified run into the subsequent years. We expect that we will keep that under review, and there will undoubtedly be new additions as work completes. There's also some actions in there around improving some of our work around co-producing with people with lived experience. I acknowledge the NHS, that underpins a lot of the work they've already done. I think for me, some of that is us joining that up for social care a little more. And I mean, Baz is here today, and we're linking with some of the work that Health Watch are doing, and again with Children and Family Services. So we expect new actions to come on board. We've included, as Julia's referenced, future actions in there. So we wanted to make sure they had visibility. They weren't quite in a place where we could agree some focus metrics that would allow us to kind of report on that. But we expect those to, once they get to that place, to come through in due course onto the action plan. I think it was important to include those so anyone reviewing the plan wouldn't necessarily spot things that they thought perhaps we hadn't thought of, which we had. And there's some key ones around there for me, things like preparing for adulthood, which is quite a big programme. I'm going to get this right place, right care, right place, right person, which I know Julia raised. So again, I'm glad Nicola's here. So if there's any queries about that, I know Nicola will know about that. So that's the introduction. The only other thing I would say is that the overall shaping the strategy was around within existing resources, and therefore, I didn't anticipate a huge amount of additional actions that may not have been deliverable in the time and capacity we've got. So it is reflective. That kind of takes that into account as well. And then over to any other questions, or I don't know whether Nicola, anybody else wants to come in at this point, or whether we want to take questions, Chair.
Yeah, let's invite your other colleagues, just if Nicola or Becky wants to say anything. No, you're not indicating, so that's fine. So, sorry.
It's just to say, obviously, we're joined also online by Lisa Egel, and Ben Richards is here as the SRO, and Chris is our sort of Chief Transformation Officer as well in terms of mental health. And it's just to really point out this has been a really collaborative piece of work in terms of how we've approached this. And very much the focus in terms of the actions has been on areas where we feel we can really work together well, those points of integration, those points of joining effort as well. And I think Jan sort of alluded to it. Our real sort of big focus is very much wanting to have our experts by experience and our service users and residents really driving some of this forward, because we know it's there. They have a lot of the answers in terms of how we need to change, what we need to do differently. So it's a really good step forward in terms of how we want to further integrate across health, social care, and also across sort of children and young people and adults, making sure that we get that transition point right for our young adults and children and young people. Thank you.
Thank you. And the other point you didn't make was it was also a readable, digestible document and not 1 million pages, which I'm sure everyone involved in the production of it will have delighted with as well. So I think it's sufficiently detailed without necessarily cutting down every tree in the world. So, committee, let's just go through questions in terms of the action plan and direction of travel. Anne.
Thank you, Chairman. And can I say I welcome this. I really do welcome this document. And thank you for all the good work that's been done regarding it. But I have got grave concerns, to be honest. And it looks good on paper. But how we're going to achieve all this in the next, coming months, I really, really have worries, put it that way. Especially working with schools, with the children. Early intervention is the main thing as far as, in my opinion, as far as mental health is concerned. So I'm really, you talk about having round-the-clock help, 365 days a year. I mean, I could go, I've got a list here of things, that my concerns. I won't go through them all because they're all there in the, what you're saying you're going to do. I think, Chairman, I think it's something that we've got to keep high on our radar, because mental health is a growing concern, and it's really, really, and I'll leave it at that at the moment. So,
could I just ask though, Anne? Could you just give a couple of the concerns you've got, because I think that would probably help in terms of a response from Julia and Jan and colleagues.
One thing, as I say, I'm very passionate about getting children early help, especially within schools, and how are you going to work with schools to get that help, to make them understand how urgent and that mental health help is as far as children are concerned. So that's one of the main things. The other thing is improving access to psychological therapy, and that there's the shortage of people out there that's got the that are trained and have got the knowledge and that to help these people. So what are you going to do to improve that? And as I say, round the clock, 365 days a year, and the risk register, which I do welcome about children. I think that's really, really important. Again, giving advice out to people. How are you going to do that? I mean, I've been to a couple of doctor's surgeries, and there's nothing in doctor's surgeries regarding mental health where people can go for help. So that's just a few of the things that... can I just mention, though, and just digress in a little minute, about St George's Hospital and the postnatal work that is being done there with mums that won't gel with their babies when they're born. I think that is absolutely fantastic, and to say the good work that they're doing there, I think is really, really good. Thank you.
Thank you, Anne. So I've got Becky who's indicated. Are we happy for Becky to go for
Can I just make a general comment that
Yes, please.
might support?
And then we'll come to Becky.
And then I'll, Nicola, there's obviously ones Nicola and Becky want to come back on. So I would hope that we have collaborated on this. So all the leads that are in that action plan, and the dates have been agreed with the lead organisations. And I think the other thing, just to reiterate, that some of these are actions that are already happening. And what we've done is we've gone, what are the key activities we're already undertaking that when we look at the outcomes we're trying to achieve in this strategy. So some of those won't be getting off the ground now. They will be off the ground and running. And therefore, that's why some of the dates look quite challenging. So I would hope, obviously things can happen, but we've all signed up to the dates within this. So, and I think some of the ones, the one about the information for people, that's quite a long lead time. And that's because I think that is one that will be quite challenging. So I think where it's additional work and it's complex, we've built in more time to those, I think, just to give that general reassurance. Thank you.
Thank you. Becky, we're with you.
Thank you very much. So I'm Becky Murphy. I'm a commissioning officer in Children and Families Health and Wellbeing team. So the section that I really wanted to focus on was the questions and queries around what we're doing with schools. So there is quite a lot of work going on with schools and has been for some time, as Jan's alluded to. This is already work that is in train. So the action plan makes reference to a really comprehensive survey we carried out across all Staffordshire schools last autumn, where we had a really good response rate. That was to staff in all Staffordshire schools, and we had 350 responses received, which is not too bad. Out of 400 schools, we had the majority of schools responding. And what we were actually asking them was, where did they feel it was going well in relation to emotional health and well-being, but also really importantly where they felt the gaps and barriers were, how they were getting on with embedding that whole school approach to mental health, so everybody taking responsibility for mental health and contributing to addressing it. So we've taken all of that for the last term, so the summer term in the run up to the summer holidays. We've done lots of work with our education colleagues and with school colleagues and others to really look in detail at what did that tell us, what were the findings, and what did we need to include in an action plan. So we've now got quite a comprehensive action plan that, as I say, we've worked up with schools to say, what do we need to do to address all of the gaps and barriers that were identified, as well as other things that we've identified during our kind of more informal conversations with schools. And the action plan outlines that will actually be delivered during this academic year, so that we're hoping when we come to do the survey again next autumn, that actually we'll see some improvements in some of the gaps and barriers that were identified. And in addition to that, just briefly, there are quite a lot of resources that are out there. So I manage a mental health leads in education network that brings together all of the mental health leads in schools from across Staffordshire and Stoke, and also from other educational settings. So, pupil referral units, alternative education, colleges, etc. And really the purpose of that group is to bring those colleagues together to provide them with the support they need to deliver on that mental health support within schools. So just wanted to mention a couple of things that we have got in train specifically around the school support.
Thank you. Anne, do you want to come back? No, I was just going to give some first-hand experience. I certainly know the local FE college here, on the bottom of all their footers, on their emails, has got a range of reference points. So some of it is happening out on the ground as well, which is good to see. So I've got a long list here. John, I think you were before Keith, I think. Assuming that you did indicate, I think.
I did, Chair, thank you. And my apologies for my lateness. I foolishly thought that 2 hours was ample time to get from Biddulph to here, even in my car, but there seems to be a plot to cut Stafford off from the north at the moment, so apologies. Right, just reading through the cracking report, really, I think it's a very comprehensive report, but I think, as one of the previous speakers said, it's one of these that looks good on paper. The devil is in the detail, and I'm shocked to see 1 in 4 kids. 1 in 4. That is as an emotional. What does it say? Page 19. Beg your pardon. An emotional well-being issue. I mean, what does that include? Is that bullying? Is it things like bullying? I'm worried about my exams. It's you know, it doesn't. I'd like to know exactly what that is, because those are the sort of things that, you know, to my mind, are part of growing up. I'm not saying they don't need looking at. And 1 in 10 teenagers diagnosed with a mental health condition. And this report as well, to me, seems as though it's tackling primarily the symptoms, not the underlying causes. And things like isolation by technology, what I call it, cost of living crisis, that type of stuff. And on page 21, it says you aim to reduce unsafe social media use. Specifically, how? How is that achievable? It's almost impossible. And on page 21, it's about prompt access to best hospital provision. And I'd like to know who triages that. Who triages what's the best? Who do you go to? Because if it's GPs, well, good luck with that at the moment with their current workload. So it's just those sort of details, Chair. Overall, I'm impressed. It's really good. But I just worry that, you know, there's a lot of detail there that seems to have been glossed over a little bit. Thank you, Chair.
I think Jan's going to take this first.
I wasn't sure whether it was that was the strategy, the action plan paper.
Yeah, I think there is. I think yes, that's certainly true that we're here to scrutinise the action plan. But I actually think I think it's a fair question, particularly as John is relatively new to committee in this role.
No, that's fine. I think some of the ones that the members raised are probably NHS references. I don't know whether Becky or Nicola want to respond in terms of the stats around number of children. Is that coming out of the NHS report, Nicola? Number of children reporting
so
mental health
the 1 in 10 is from the psychiatric morbidity survey. So it's essentially that 1 in 10 children and young people could have a diagnosable mental health issue. I think in terms of the 1 in 4, I think you're correct. I think that's broader around sort of emotional well-being, those broader issues. So there is a difference between the sort of broader emotional well-being and then having what requires a mental health intervention or a mental health support. So the two are a little bit different in terms of that. In terms of the sort of good hospital care, we have across Staffordshire and Stoke-on-Trent a very good sort of crisis response system in place. So we have 24/7 urgent access helpline provision. That's supported by crisis resolution and home treatment teams that are able to do that sort of assessment of individuals who may require a hospital admission. So wherever possible, obviously, what we try to do within Staffordshire and Stoke-on-Trent is to support people within their own home where it's safe to do so. But obviously there are times when an inpatient admission is required, and that will be facilitated. And then the focus then is on that inpatient admission stay being, you know, high quality, really purposeful and therapeutic, and then obviously with the aim of getting people back into their lives and their communities as soon as possible.
Can I bring in the Cabinet Member as well now, please?
Yes. I've got the data here that you're referring to. I think one of the things with our society now, thank goodness, we've more aware of mental well-being and its importance. We've always been aware of physical well-being, but the mental side has either been taboo or it's not been recognised. We now recognise it, and particularly with young people, but it's with people of all age groups. It doesn't necessarily mean that somebody's mental health needs medical intervention. And I think one of the things this strategy recognises is that, I mean, you know, I'm getting long in the tooth, but I can remember when I was young, and your emotions, it's girls and boys, at a certain period in your life are all over the place. You know, one day you feel great, the next day you feel as though the world's going to end. But it's enabling people to access that information and health. The first thing I think is really important for people is this is not unusual. A lot of this emotional turmoil is actually quite normal part of one's development. But it's actually making sure, and this is the work that will be going, is that in different formats, information is available to help people, in effect, to help themselves. Because to be perfectly honest, if we medicalised everything, the system would creak, the system would collapse. And that's, you know, we have to be honest with people. And I think what we need to ensure is that for those people who can, through information, perhaps support groups, manage their condition and overcome it, it then allows the clinical, the social care, the health services to deal with those people who that medical intervention, that social care input, whether it's children and families or adults, that is available to them. So, I mean, my view is this is ambitious. It's got to be, unless you, my mother always used to say to me, unless you head for the stars, you won't even reach the moon. You've got to be ambitious, but I do believe it's deliverable, because this is a really good piece of partnership working. And I hope this kind of close collaboration with the NHS actually infiltrates into a lot of work that we do, because actually by pooling our resources, we actually get better value out of it. So I think this is ambitious. I don't apologise for that. But because the key elements, the people who are going to deliver it at the sharp end have actually signed up to achieving these targets. That doesn't mean there's a guarantee we'll achieve everything. And this plan will need to be reviewed, will be developed. But I think that's one of the key messages. We mustn't medicalise every condition. We can't carry on doing the same old, because we'll get the same old results where people can't access the services they need, fall through the gaps. We need to do things differently. And I do genuinely believe that working closer with the NHS to close those gaps, to pool resources, we get better value and we get a better service delivered for those who actually do need that help and support, which may go on for years in their life. Thank you, Chairman.
John.
If I may, just quickly, Chair, yeah, I accept all that, but it's just one of the things I mentioned when I spoke first. Just one particular issue. It says, it blithely says, reduce unsafe social media use. How are we going to do that? How are we going? I think the internet's the most beneficial thing and the most poisonous thing that's been brought along in the last 30 years, quite frankly, and for youngsters in particularly. I mean, it was bad enough. I was a fat kid. I'm still a fat chap. When I was at school, I used to get pilloried because I was a fat. You know, now you're going to get pilloried by more people because you're online and you want to post photographs. You know, people want, and it's just an insipid poison. And it's here. But how are we going to do it? Somebody tell me, one of you tell me, what specifically is going to be done to try and do that? Because that's a root cause, that's not a symptom. That's something we need to do something about. And I honestly think, I'm not expecting an answer because I think it's an impossible task. It's a laudable aim, but that's just one specific issue I've picked down. Thank you.
Can I just make a very brief comment, which is we're here obviously this morning to review the action plan, not the strategy, because we've done the strategy a while before. But I'm happy just to help see if we can provide that loop. Julia, Jan.
Thank you, Councillor. Yeah, just to sort of firstly reiterate, I think what Julie's covered, which is the strategy. Obviously, it's inclusive of mental wellbeing and mental health, so it is important that we try and set. So some of the bigger numbers are around wellbeing, which the aim of the strategy and the action plan is to improve wellbeing, mental wellbeing, which will kind of hopefully reduce mental illness. And actually, people with severe and enduring mental illness is a relatively smaller number, and therefore the strategy is very broad in that it's covering the whole range of that. Around the safe social media use, I'm hoping one of my colleagues, Becky Smart or Sarah, because I think this, I do recall this coming in. Becky, I think, has got a hand up. So I'll let Becky speak a little bit about that, because I think there is some work going on. If I could hand over to Becky.
Becky, we're with you.
Hello, yes, and just to set expectations, I'm absolutely not going to be able to say how we're going to resolve absolutely the entire issue around harmful social media use. But what we have done under the auspices of the ICS Children Young People's Mental Health System Improvement Board, we have a number of work stream groups that have been set up to look at particular elements of this whole work. And I'm leading on a group looking specifically at prevention, which feeds very much into that emotional health, emotional well-being side of things. So it's not necessarily children and young people who have diagnosed mental health issues, but it's perhaps those children and young people who are more at risk of developing those as they get older, but also those groups that we know have poorer outcomes generally, for example, care experienced children and young people. In terms of the social media use specifically, I think I'm probably getting to the point now where I'm a little bit old to be part of that target group. So what we're intending to do is ask children and young people themselves. We know that the internet can be absolutely a force for good, and lots of the tools and resources we provide to children and young people to help them manage their own emotional well-being are online resources, because that's what they tell us. They go to the internet for their information and support. But actually we're also going to ask them, and we have started asking them, about the flip side of it. So what the elected member referred to, it's absolutely a huge mountain to climb. I don't think we are going to resolve all of it in Staffordshire, but I think by asking Staffordshire's children and young people and schools, what do you think will help you tackle and address some of those issues, and then respond to what they tell us. So as at today, I don't have all of the answers. We're just beginning work on developing that prevention action plan, but I'm hoping to have some real clear and measurable actions within that prevention action plan that does look at how we can increase the benefit of social media. So how can we use it to promote mental health and good emotional well-being, but also what safeguards we can put in place to protect children from some of the more harmful elements.
Thank you. John, is there anything else that comes from that?
No, thank you, Chair. I won't hold the microphone much longer. It's just, I think strategy is very easy to put out. I mean, the guys in 1914 sat in the chateaus, had massive great strategies, but they didn't take into account the muck and the bullets on the ground. And I think, you know, it's very easy to say, we're going to do this, we're going to do that. But unless we've looked at the detail how we're going to do it, then I think we're going to struggle. But as I say, I'm not expecting answers, because, in my opinion, it's an almost impossible task that some of the root causes. But thank you for letting me speak, Chair. Thank you.
Becky, can I just ask a follow-up just on that? Where do we find the answer you gave John a minute ago, which is related to the Children's Improvement Board piece of work that's going on? Where do I find that within this paper action plan?
There are, if you bear with me a second, I will just get my action plan up in front of me. So, and I think it's within the future actions. Action 1 in the future action section, and apologies, I don't have the same paperwork as you have, so I can't direct you to the page, but we do talk about developing a partnership children young people mental health prevention action plan, and that talks about that work that we're doing there. So it doesn't refer specifically to the social media, specifically that area of work, but it talks about the work we're doing to develop a prevention action plan, and that will include universal prevention, targeted prevention, community resilience, and communicating the prevention offer. The reason why it's in the future actions and not the current actions is because that action plan is actually being developed as we speak. So we are working on what the actions look like, who's going to be leading on those, the timescales and the measurables to tell us when we've achieved what we're aiming to achieve. But if you look in the future actions, there are a couple of references to the prevention action plan there.
Yes, thank you. It's on page 34 for committee, and it's the third block down. Understand that, but it's always good just to follow through the actions, just to make sure that it is... You see, I wouldn't have worked out from what you said versus what's on the paper exactly all the depth of that. So maybe for I don't want action plans which are hundreds of pages long, but you know, maybe there is a bit of more narrative to them to make them more rich in their detail. Keith, let me bring you in.
Thank you, Chair. And I think some of the response we've had so far was something I was looking at. I have two questions. and an observation. I mean, obviously we're looking at the co-production of many of these things, so I understand that one person can't necessarily answer the entire question at this stage, because at this stage it's purely just an action plan that you're looking at to support the strategy. I understand that with the 6 outcomes and the 7 approaches. So very good, got to that bit, I can understand that bit. I do think, though, that we could do with some more detail in time. I'm not saying it's something that we need to know now. Obviously, a lot of it is you're getting the information at the moment. Just an observation, and one of the questions I have is that out of the 6 outcomes, at least 4 of those are dependent upon work within the communities. And I think that's something that certainly ourselves and Anne and others have been looking at for many, many years, including with the schools and everything else. So my question really is, at the end of the day, is how are these things going to be developed? I know that we know who's going to do it, because in your action plan, very good, you've got who's going to be doing what and all the rest of it. I just think the word how, which I think John's already hit on to a certain extent, I think, is that a piece of work that's going to be coming to the committee in time, in terms of how some of these things are going to be worked out? Because I do think there's quite a lot of elements here that ourselves could input. And I must say, at this point, I'd like to bring in a comment that I made from the working group that we've been doing with the Staffordshire Connects, which answers some of the questions that we've already been listening to and everything else. You know, it's good. It's still in development and everything else. And I still think that's something that we could all feed into. And it would be great to see what the schools and young people and everything else would like to try and do, and maybe have a section within Staffordshire Connects just for young people, you know, or for schools, or how that's structured is something I think is still ongoing, and that was one of the suggestions I didn't suggest at the workshop because we didn't have much time. But anyway, I thought it might fit in at some point, but there you go. But it's that use of technology that we're all going to have to depend on. We can't have people answering phones all day and every day. That just is, you know, that's how it used to be, and it was very limiting. I think the idea of having multiple people looking at things and then getting the specific details, the way it wants to be and linked into the communities, you've already got a tool there with Staffordshire Connects. So why not try and expand that a bit more, bring in NHS, whether they have the version of it or whatever, you know, how that's all going to work in partnership and this co-production, I think is very interesting. So I don't know who's going to take that one. That's more of a overall thing. And then lastly, the one area that I do think hasn't been mentioned too much in this, going through everything, is training and or staffing levels. We're already short, particularly within the NHS, of areas where we need people and we need expertise and everything else like that. I mean, it sounds a little bit like we're going to have to train ourselves to become experts in some of these areas, as just demonstrated. So I do think that I'd like to have an answer about people and how that's going to develop as time goes on, particularly with this co-production. And working with the communities. Does any of those questions make sense? I'll shut up at this point. I hope that all that makes sense.
So we're with you, Julia. Thank you.
Thank you.
This shows the real value of scrutiny. It was a very good session that we had on Staffordshire Connects and how we're modifying and improving that. And I think the suggestion of perhaps developing a separate section specifically modelled to be attractive to children and helpful to children is a very good suggestion, and I'm sure Jan will pick that up with our public health colleagues. So thank you very much for that.
Jan?
Thank you for those comments. That's really helpful. So just to come on so one of the actions in there that looks quite, you know, it doesn't stand out, which is around co-producing an approach that allows people that are seeking support to know what's there and how to find it. So I think for me, one of the biggest things that came out of the engagement was that people don't always know where to go for support. So when we did the public survey, which we went to sort of over 600 people, when we said who would you go to talk about your mental health and well-being, everybody said family and friends or a professional GP or a social worker. And actually that left a whole gap around some really great voluntary sector, third sector services. That, and again, Julie, I think referenced earlier, we won't have enough resource. The NHS won't be able to treat every single mental health or mental well-being issue that people have, and nor will social care. So I think for me, that one is big, and you can see we've given quite a bit of time to that. What we also found is that when we worked with Becky and her colleagues, children's have already got some work in progress. I know there's a lot happening already with our NHS partners, and I think the key thing around that is how we work together, so people that are looking for it can find it. So I think this one calls out for co-production with members of the public and people with lived experience, because it's quite hard when you're internal to know when you don't know anything, how you would go and look for it. And I think everybody I've spoken to in the development of the strategy and the action plan thinks this is an area where we could try and work together. The other bit of feedback that came through all the engagement and when we were talking about developing the action plan is parents and young people, when they come to 18, they often say this, it's falling off a cliff, it's completely different once you're an adult. And so what we want to look at is not necessarily, may not be one solution that for all age, but certainly that takes into account that if you've got a mental health problem at 16, 17, you might likely still have one at 18. And so people want to be able to be prepared about where they might go next if they still need support. So I think for me, this is one of the ones that looks doesn't jump out, but certainly colleagues that I've spoken to who are leading on some of the engagement and co-production in the NHS providers would say that this is something we definitely could work together more on. And again, there are a particular group for me who might have long-term mental illness, and they've got social care needs. And again, it's making sure that we are taking them into consideration as well, and how they can find out what support. I did attend a service user and carer group when we were doing the action plan, and what was interesting, and they were people that had long-term mental health problems, but they agreed they wouldn't necessarily know how to look after their mental well-being. And again, this came through in the strategy engagement, which is about they can exist together and independently, and again, it's making sure information's available. We do work very closely with public health colleagues who are leading on the IAG and things like Staffordshire Connects already, and that will continue on. And you can see that actually this action in there has got loads of leads on it. So we've got leads from the ICB, Children's, Public Health and myself to indicate that that is absolutely a collaborative one, and that will involve working with people in the public in Staffordshire who may not know yet that they need help, and that we need to kind of work with them and not just people who are already receiving care and support, and that's a kind of a more of a challenge to find those. I don't know if that helps at all. Nicola, I don't know whether you want to come in on staffing.
Yeah, there was a piece on staffing and training, wasn't there, that Keith asked?
Yeah. So workforce, as we know, is an issue across the piece really, and making sure we've got the right sort of trained professionals. So across Staffordshire and Stoke-on-Trent, we have a specific mental health workforce plan that we look at with our colleagues in NHSE and HEE, where we plan essentially for the next few years in terms of the workforce that needs to be in place. We have very specific training plans around certain services. So, for example, services that people might know as IAPT, which are called talking therapies. There's a very specific expansion programme there in terms of training. So there is a lot of attention that goes into that sort of area. But I think one of the key things that we've been really keen across Staffordshire and Stoke-on-Trent to do is to make sure that we're using our workforce, our clinical and social care skills as effectively as we can. So by widening our range of roles, so within the voluntary and community sector, for example, where people might be better placed to respond to some need, which then allows our clinical and social care staff to really focus on the areas that they need to focus. So it's not really just about the sort of NHS workforce or the social worker workforce, it's about that wider aspect that we need to have in place to actually respond to the level of poor mental health and mental illness that's out there. And very much we see certainly the roles within the voluntary community sector, and certainly the roles around paid roles around people with lived experience and peer support workers, peer recovery workers, being really part of that workforce that we need to have in place to make sure that we can meet need across Staffordshire and Stoke-on-Trent moving forward. So it is an area of focus, but it's a challenging area, and it's just recognising that.
Thanks, Keith.
Yeah, thanks. It's great to hear about the workforce plans anyway, but obviously we need to try and set up what we want in Staffordshire to some extent, so this committee can then see how well that's going. I do think that quite a lot of this you haven't got targets or anything like that, and also the figures quoted at the beginning were, I assume, more national figures than they were local figures. So it might be slightly better in us, and we can then redirect our services elsewhere. But working with communities, I think, is definitely the way forward as far as I can see. There's lots of people out there. It might not mean much training, but just enough to be able to then support what you're doing, and you'll find that hopefully the pressure might be and relieves a bit if it can just all be done online rather than having to import the whole system and go through things that might cost us an awful lot of money, you know. So, oh, go on, sorry.
Just absolutely, that's a really important point, because it's this whole aspect around mental health, mental well-being being everybody's business, isn't it? And actually it doesn't just sit with NHS providers trusts or just sit with social care, etc. It's about really ensuring that the whole community is able to respond to people's needs. And again, that's the sort of piece around reducing that stigma and discrimination around mental health as well. That's a real sort of area of focus for us. So absolutely, that's a really important point. Thank you.
I was going to go on to say about the fact of working with partners at district and parish councils, youth clubs, all these sorts of things we have access to. We've had some great success both at parish level, town levels and all these other areas, and it would just be great for them to feel part of something rather than just being sort of sidelined somewhat. So I do think that that's something that could really work well, and I hope that you can bring that into the plans a little bit more, and it's something that we could maybe look at from because under this committee there are district committees as well, and it would be great to have those involved as well within the local things. The one area that I was a bit concerned with, I had a chat with the chairman at the beginning of the meeting, is that North Staffordshire, you don't separate out the Moorlands, Newcastle and Stoke-on-Trent on facts and figures at the moment. So we don't know necessarily as representatives of the Moorlands as to whether or not how well that's going and where we need to concentrate our comments and our future, you know, targets, if you like, collectively with yourselves. Thank you.
Just if I can pick up a couple of things. As we've got social prescribing and the workforce plan coming to committee later in the year. I know the social prescribing is not specifically about mental health. It is, but it is part of it. And then maybe the other one in terms of Staffordshire Connects, look to have a youth section or a young person section. I think the key thing there in terms of, for me certainly, is making sure it's age-appropriate content and communication. Because if it is, then it really hits the mark. And what works for a 6-year-old doesn't work for a 10-year-old, doesn't work for a 15-year-old, but I'm sure that's in hand. And maybe some of that material already exists because there is a lot of work that goes on through the districts and boroughs, as was referenced earlier, within schools. And certainly Stafford did some work creating a website with information on that. And maybe some of that stuff is there that can really create something which is really valuable alongside the work you're doing. Can I move to Janice, please?
Perfect timing, Chair, actually, because I've got a follow-up question myself, actually, on that one. Just to start by saying, I'm really pleased to see the content of this report, and I think that it is extremely accessible, Chair, from your original comment, and certainly in terms of the detail that's in there. It's opportunities like this where we come to ask questions in a positive and hopefully supportive way, as opposed to having a 686-page report, which sometimes happens, but I think this is extremely accessible in its format. And I'm also pleased to see the ambition. You know, it's easy sometimes, and I think that you might have mentioned earlier on about other projects being enormous. I'd say this is pretty sizable, in my opinion, and some of those big-ticket ones haven't been shied away from, and the fact that we're looking at social media is being identified and the plans accordingly, I think is also absolutely commendable. If I could just ask one sort of overreaching question to start off with, and then I've got some specific ones with regards to the contents of the actual plan. Co-production. I am absolutely heartened to see the amount of people and the resource that's being put across this, even just for our meeting today. We also know the stance of police forces across the country when it comes down to responding to mental health crises and the fact that some of that maintains, but also our own Chief Constable locally has said that officers are spending too much time looking after vulnerable people rather than tackling crime. And with regards to co-production, I just wanted to know what sort of involvement that there's been with the police. So I know you mentioned earlier on about when people are needing to access support, they may go to their GP, they may go to family and friends. I think instinctively it's also, in a lot of cases, to call 999. So just to see what reference and what sort of liaison has been going on with co-production with those, because I think they're also a pretty significant stakeholder within the response. It would be my first question, and then if I could come back with the others specifically afterwards. Thank you, Chair.
Jan.
I'll come in first, but I'll probably refer to Nicola Bromwich about the particular issue around right person, right care, or right care, right person. I keep getting it wrong today. So in terms of the wider co-production, I mean, it's core particularly to how the NHS are transforming mental health. And that is an area that certainly within the County Council that we are aiming across a wide range to increase. So it's core to how we've developed the strategy, and we will go on to develop the actions. Some of the actions in there will already have been developed with quite a reasonable amount of co-production in there. I think there is more that we can do, and that's why there's some specific actions around there. So, you know, that will continue on to get the kind of input. In terms of the police, we did have some engagement. Obviously, it's a while ago now in terms of the strategy. Some of that was kind of came sort of most powerfully where we kind of, I attended a couple of sort of vulnerability hubs that they have in localities, and I think the District Council and boroughs are very important in this. And that is where it's genuinely multi-agency working, and there you would have police, fire, housing. And I think there was some very good feedback through those and through particularly housing colleagues around a kind of accommodation used, that sort of emergency accommodation, places of safety for people. So I think going forwards, there will be some areas particularly where it will benefit into further liaison. So I think in the report we've referred back to. So for me, we did a lot of engagement developing the strategy. We've pulled together the action plan. Actually delivering that action plan will require lots more connections to be made with those partnerships, including police, district and borough councils. There's a number of actions around housing. So I think it has happened, and I think there'll be a number of actions where that will be core to it. I don't know whether Nicola you want to come in now on the...
Yep, so in terms of mental health, we do have some specialist provision in place with both our trusts that provide that specialist advice and support to police, so that's already in place. And we have a number of sort of interagency meetings around specific area focuses, so things like the Section 136 aspects and things like that. Obviously in terms of right care, right person, that has obviously received a lot of national attention, hasn't it, in terms of how it's been deployed elsewhere in the country. Obviously across Staffordshire and Stoke-on-Trent, we've obviously benefited from the new Chief Constable, have I got that correct? Yes, in terms of his experience in Humberside, and they are very much seeking to take a very co-produced, collaborative approach with us in Staffordshire and Stoke-on-Trent in terms of phasing that across the year. So we've just had the national sort of agreement that's been sort of published a couple of months ago. So we'll be working through that very closely with our police, our colleagues in Staffordshire Police. But it's going to be very much a collaborative, co-produced process in the spirit that it should be intended. So there's work planned through the Mental Health LDA, Mental Health, Learning Disability and Autism Portfolio Board that Ben's the SRO of, and Chris and Lisa are sort of integral to that as well, in terms of how we manage that moving forward. But it's very early days in terms of that phased approach. They've had a few engagement events which I think have been quite well attended by different people across the patch, but very much that's part of our thinking. And again, under the Mental Health LDA board, we're establishing a specific mental health urgent emergency care work stream that will hopefully pull together some of the different deliverables that you've seen within the action plan around things like the improving ambulance response, the NHS 111 option 2 mental health response, and things like right care, right person, and how we do that to make sure that our communities get the response they need from the right people at the right time in terms of their mental health. But it's one that we're looking very closely at.
Thank you, Chair. Yeah, I think that that level of collaboration I didn't necessarily see, and I think it is such a critical thing that we are obviously all working together. There's all finite resources in whichever agency, and that they are complementary and working to support each other, I think is critical, and especially in this nature as well. My other questions, if I'll go on to those ones specifically, so if I could just pick up on the mental health workforce plan. There's a reference in the report in the actual plan about growing CAMS workforce. And I take your point, what you said about the voluntary side, but certainly in some of those specialist roles, and if we could just take CAMS as an example of that, how the intention is to try and grow that, I think would be helpful just as a headline, if I may, Chair, prior to when we receive fuller details in future. And if I can give you the other couple as well, if that's okay, so we'll just do the three. There's reference to people with severe mental health problems benefiting from new models of integrated primary and community care. I think it might be helpful to just give us some idea of what we mean by severe mental health problems and how that is likely to take place in the community environment. And finally, I will declare that obviously I am a county councillor for Lichfield, so I was pleased to see in particular reference to an implementation date for Lichfield. My particular division is City North. Again, if we could just have a bit more detail on those support teams, the size, the frequency, their presence in the schools. And I'll also declare, obviously being a former secondary teacher as well, that there is some type of vested interest in that as well. But just to give us a bit more of detail on those would be helpful. Thank you.
Thank you. So in terms of our children's mental health workforce, so a number of those roles obviously will sit within North Staffordshire Combined Healthcare and MPFT, but we also have joint provision in place with Staffordshire County Council in terms of Action for Children, which is a service that supports children and young people with mental health issues. So again, when we sort of talk about that expansion, it isn't necessarily just within the sort of what's seen as the CAMS workforce within trusts, but it's actually how we do that with other providers and start to increase that. A number of the increasing roles are, as you sort of rightly point out, around mental health support teams in schools. So that is particularly growing the sort of what we call education mental health practitioners, that are those roles in place, and also the community wellbeing practitioners. And again, a big part of the workforce aspect around children and young people's aspects is around that sort of psychological therapies and those talking therapies. So it's very much skilling up different elements of the workforce to be able to deliver that. But we do need very much to grow our children and young people's mental health response. And it goes back to the councillor's point at the start of the meeting, really, that actually to make the difference, we need to get in there as early as possible and to make that short sort of shift. In terms of the mental health support teams in schools across Staffordshire and Stoke-on-Trent, we've been really successful in terms of our ability to lead on this element, and have got sort of a lot of national recognition in terms of how we do that, and we very much do that in partnership with our local authority. So Becky on the call is really heavily engaged in how we do that and how we engage with those educational establishments. We've got I think 9 mental health support teams in schools across the whole of Staffordshire. Obviously we've got some in Stoke as well, which gives us really good coverage. So I think we're heading, when the next team comes in place, which will be in January, we're heading for about 45% coverage of Staffordshire schools at the moment. Now, that still means there's 55% of schools that don't have access, and obviously that's part of the sort of ambition that we were alluding to in terms of some of the plan takes us up to the end of this year, and then we'll have future plans in terms of expansion. We're working on that sort of Lichfield District Council sort of area in terms of priority for this sort of cohort that I think would have started, I think, last week in terms of their training. So obviously it's about how we embed those and rolls those out. So we're in different places depending on where you are in the county in terms of how established those mental health support teams are. So, for example, the teams in Newcastle and Moorlands were one of the first sort of trailblazer areas, so they're very well embedded. So the ones in East Staffordshire, but the ones in sort of Stafford area, Cannock Chase, are newer. And I think, as I say, it's a sort of national pilot, if you like. So we're still in a phase of learning, really, in terms of, you know, what are the best interventions, how can we best support children and young people. So that is still sort of ongoing. So hopefully those have picked up both of your questions around sort of children's and mental health support teams in schools. The other one, which is around, you know, what is severe mental illness. So within the Community Mental Health Transformation Programme, there's a definition. It's quite a technical definition, but it includes sort of different diagnoses like schizophrenia, personality disorder, you know, very severe depression, aspects like that. I think what we have done across Staffordshire and Stoke-on-Trent, and I don't know if Lisa or Ben would want to come in after me, is very much take an approach about, well, what is right for our residents, what's right for our service users and patients and families in terms of making a difference. So we've really broadened out our community mental health offer to make sure as many people can access that support at the right time, and very much we've done that in partnership with our voluntary community sector partners, where we've got specific VCSE partners who lead on potentially, things like making sure people get the right benefits, sort of debt advice, because we know that can be a big impact on people's mental health, making sure people have got the right support around tenancy and accommodation, because again, if you don't have somewhere safe to live, that has a really important, a really big impact on your mental health. So we can deliver really great intervention in terms of psychological interventions, but if you're not safe in your own home, then it's, you know, it's all of those aspects. So, and it very much is about that sort of breaking the boundaries between sort of primary care and secondary care as well. So we have a number of roles of what's called, we call them mental health practitioners. I think the technical term is mental health R's roles, which is additional reimbursement roles. And very much they're about bridging that gap, really. So they're providing that workforce that's in primary care, but actually making sure that that then there's swift access into secondary care or into services like talking therapies as swiftly as possible. So again, we've had we're in year 3 of that expansion now in terms of community mental health and those mental health R's roles. And again, there's more to do, and that's kind of features again as part of the action plan. But there's lots in that space, and we could take an hour up just talking to you about community mental health, to be honest. And we are very happy to do that if you want to invite us back to another session. But yes, so there's lots going on in that space. Sorry, Chris, did you want to?
Can I just bring in Chris, please?
Thank you, Chair. I just wanted to pick up briefly on the link between primary and community healthcare. So I think we have, Nikki talks about the mental health R's roles, which is quite right. There are a range of roles that are covered in that umbrella term. So there are things like first contact physios, first contact paramedics, etc. And there is a link there to our general practice strategy, which I think we brought a draft version through this committee some months ago before it was approved at ICB board in April. But a central part of that is the concept of integrated neighbourhood teams, which seek to align community services, including but not exclusively mental health, around general practice, with the person at the centre of that. So that's been in place now. As I say, it was approved in April. It's been in place for some time. We'd be more than happy at committee's discretion to bring through an update on the progress we've made around that particular strategy.
yeah, I think that will be helpful. Certainly, one of the things that I was looking at, and I appreciate it, you know, with regards to the safety of the service users on there, but I think it might be also worthwhile just taking a little bit of comment to look at how the wider community is also, their safety is maintained. The people who are going to be living in and around those areas as well. Thank you.
Thank you. I think there was two recommendations, or a recommendation at least, maybe to review the community mental health plan at some stage in committee. Maybe we'll take that as part of the agenda planning later on in the committee. Baz.
Thank you for that. Yeah, I mean, there's quite a lot of stuff there, but what I want to say is really, really reassuring, and as a Health Watch as well, we have been working in partnership to co-produce a couple of these deep dive areas around, especially around mental health, and as you mentioned, the R's roles, so they are really working well. Just a couple of comments more than anything else. One about the social media that was mentioned. I know from our own experience, our kids' school, for example, they had concerns around what some of the children were experiencing and the stuff they were viewing on social media and the internet in general. And what the school didn't shy away from it. They actually called the parents in, they informed us, and it's kind of bringing the idea of the collaboration, the co-production. They brought the parents along on the journey. They interacted with us. We have an app with the school. They keep us informed, and they kind of put the pedal down on that and really went all out to really, help the parents understand how to keep the children safe. So it's kind of using those wider resources and not feeling it's just individual. That's what's really, really good. A couple other things I wanted to mention also is about what we're picking up as a Health Watch, especially from the patient perspective, was about the waiting times when referrals come in. And one of the recommendations we'll be making as well, and again, as we mentioned, it's about working with those other voluntary organisations, such as Mind or Action for Children, Starfish, Stars and Changes. And I know, having previously worked alongside Changes, they do really offer some good stuff around 12 steps programs and mental well-being. So a lot of the time it is about helping them to support themselves, maybe through good peer support work as well. And a lot of young people do mention how when they have those positive groups they can talk to each other, that's really good for them to help move forward rather than feeling lonely or isolated. So I'll stop there. That's what I want to mention.
Thank you. Does anyone want to pick up anything Baz talked about? Otherwise,
I can just come back in to say
thanks, Jen.
that, just to reiterate, obviously we've linked in with Health Watch around some of the deep, sort of through developing the strategy and now into the action plan. There's a particular deep dive referenced in the action plan around care experienced children and their mental health, which I think the outcome of that will inform any amendments to the action plan, so that we have got that in hand. And then the other thing is to reiterate that I think some of the public health and prevention element of the plan builds on Baz's point around people where to know where to go for support, so people aren't waiting on waiting lists. To find, again, some of the feedback we had from people was they waited and then they were found that it wasn't quite the right solution, or they didn't meet, not necessarily a threshold, but in their eyes they kind of weren't ill enough, or it wasn't significant enough, or their perception of that was. Whereas actually they could have got some support much earlier from an alternative, which might have actually prevented their health deteriorating. So I think, again, that is very positive, because I think that's come through very strongly through the engagement, and we have got some good independent sector provision in Staffordshire. So again, we will be very much working with them in the delivery of the action plan.
So can I just ask a question? I mean, it's clear that you've got that dialogue between yourselves and Health Watch Staffordshire, which is clearly a good thing. What about the engagement of some of those big voluntary sector organisations like Andy's Man Club or Talking Benches or those sorts of people? Because, they are on the ground practitioners within the voluntary sector. So how have you engaged with them in terms of this action plan?
So we will, so I think that we've had a surge of engagement in developing the strategy, which then obviously the action plans led off that. And we did have focus groups with some of the voluntary sector and individual discussions with some of them. And and that highlighted, that kind of gave us insight to the range of offer that they got. So yeah, we had quite a lot of, I mean, I'd worked on, this is random, but the vaccine rollout, and actually I built up quite a lot of links through that around the voluntary sector, and that was really insightful because we dug into what kind of things they actually did. And then, so some of the other work we've done, that's just one example, where we've kind of made those connections, or we've raised awareness around what they're doing around mental health. So I think you know, we spent quite a lot of time in developing the strategy with a range of groups. And their feedback was absolutely crucial to how we did the strategy. So I think now the work for me and partners is to make sure we pick all those relationships back up, which is referred to in the scrutiny paper. So I think now we've got the draft action plan. We'll take feedback obviously from the committee today. We've got an ICB board, I think, to take it through. And then I think for me then it's kind of reinvigorating those connections to look at how some of those specific actions jump out for me. Things like the information, advice and guidance actions around where people go for support, they will be fundamental to that. So we make sure that when we talk about where you can go for help, we mean that as well, and we do in the action plan.
Thanks. Just before I bring Baz back in, I mean, I think two things flow from there. One is, and I think you sort of referenced this earlier, sharing the action plan and the strategy as widely as possible, because I think that's one good way of making sure everyone's bought into it, but also, you know, keeps everyone honest effectively. And I think the other one is it allows you to check that it resonates with all partners. I think that makes it a more living document. Sorry, Baz.
No, that's okay. Thank you. Yeah, I just wanted to add to that. We do have the advantage where, because we work within Support Staffordshire, they have a lot of members within the VCSC sector, over 1,300 members, and we do have our own Health Watch intelligence network that's spread across that as well. So what we are trying to do to help support this is any good information, advice and guidance we pick up across from partners, we do feed that across those networks, so it kind of gets out, such as the carers groups or PPGs, just to help push that information further back out again.
Thank you. Really helpful and insightful, and good to sort of see that going across multiple areas. Charlotte.
Thank you. First, apologies for my lateness. This is obviously a very ambitious plan, and given that mental health has always been more poorly funded than physical health, what additional resources have been made available for this plan for this strategy to be carried out? I mean, it relies a lot on community involvement, and I know of many community and voluntary groups that are run on a shoestring, and at the moment, because of the cost of living crisis, are struggling to survive. So, you know, given that this plan does rely so much on the community, self-help and so on, what assistance is flowing to those organisations on which this plan is very much based? That's the first question. The second question relates to future actions. Again, the Action 1 relies a lot on partnership, but then, and it's got a number of actions against that. But then when you look at Action 2 and Action 3, people have access to services and timely response to crises, there's just a blank, a complete blank. And I would have thought that anyone with mental health issues would want, to have a timely response to crises, but also would want to have access to services. So why are those crucial parts of future actions blank?
Thank you to the elected member for your comments. So if I just try and deal with them. So the original strategy was developed, and I think and I've referenced that in the scrutiny supporting paper, was developed to reflect that the strategy will be delivered within existing resources and existing capacity. So there is no specific new funding. I mean, Nicola might want to come in on the NHS funding. Obviously, the NHS have had specific funding around mental health, so Nicola will come in on that, no doubt. And that is reflective in this, because obviously some of that additional funding is reflected in the action plan. So it isn't, the actions in there should not be dependent on additional resources or funding for specific. The resources that we've already got allocated within the county council and the NHS should be sufficient to deliver the action plan, and that is what everybody's signed up to. In terms of community input, and I appreciate that some of the feedback we often get is if we all go out asking separately for input to things, people can get frustrated because we ask lots of people, and again, co-production is a brilliant premise, but obviously that relies on lots of people giving their time. So I think for me, what we are certainly mindful of that. I think what we can do is kind of not try and assume that they're going to pick up work to do, that the effort needs to come from officers either within the NHS or within the county council. We're seeking them as experts by experience to contribute to it rather than take on the kind of specific delivery of the actions. We obviously do rely on the goodwill of people who've got experience or contributions, but we have found through the development of the strategy that people are keen to get involved. So when we developed the strategy, when we did the public survey, we had about 200 people that wanted to be kept informed on the development of the strategy. We did a feedback session. Now, obviously, we didn't get 200 people involved, but we've developed a bit of a group of people who have got an interest in it. What we're also doing is making sure that we are linking in from a county council perspective to the NHS, so that we are often working with people with issues, and they might be the same people. So we aren't starting something new, but we're going to be working together in the delivery of strategy and the co-production. So we're not asking separately for people to give input to the work we're doing.
I mean, I take up your point that there are lots of people who want to get involved in mental health, but there's still costs involved. You know, there are premises, there's lighting, there's heating, you know, there's transport, and community groups can't exist on nothing. And as a result, I mean, in my own place, I mean, there's Rethink, there's Borderland Voices, you know, organisations like that do great work and have been doing it for a very long time, but you know, are always threatened with closure because they can't meet the costs, and particularly over the winter. You know, they're dealing with vulnerable people, and they are relied on by the statutory agencies, but actually they're expected somehow to find the money, because it's not about lack of effort or volunteering or commitment. It's the fact that there are costs involved, and they can't always be found by some philanthropist, you know, giving the money. That's the first thing.
So I think you made that point. Can I bring it in, Nicola? Because I think the bit we haven't heard is the additional resources coming in from the NHS side, which I think is relevant to the point, if I may, please.
Yeah. So for the NHS, we're very fortunate to have what's called the Mental Health Investment Standard, or MIS for short. And that essentially means that we have to grow our investment in mental health. So that includes children, young people and adults at a higher rate than all of our other provision. And that investment is very much targeted or ring-fenced at specific areas. So it has to be spent in, you know, adult mental health, for example, or children's mental health. So that has been in place and has been in place for a number of years, and we're very carefully audited on that as well in terms of how we meet that standard. So, for example, across community, if we take the community mental health transformation as one area of a deliverable within the action plan, over the past, we're in, as I say, year 3, so the investment that's increased in that this year, obviously with inflation, is about 6.8 million that's gone into community mental health across Staffordshire and Stoke-on-Trent. And that hasn't just gone into provider trusts, it's gone into the voluntary community sector as well. So there has been opportunities through formal tendering processes for various different voluntary sector providers to put forward their proposals and have contracts in place that sort of Baz was referring to earlier, and there have been some very successful organisations. We have also, over the past couple of years, had a sort of small grants process as well that we've implemented. So I don't know, Ben, if you want to talk a little bit more about that, but that's aimed at those groups that just need that little bit of extra support and then actually can deliver those bigger outcomes but aren't necessarily in a place to have the bigger, larger contracts.
Thank you. Ben, good morning.
Just to add on that, so just I suppose another example of our co-production agenda, so grants of up to £20,000. We got the Community Foundation to manage those on behalf of Combined and MPFT, and we've done them around themes. So the last theme was around children and young people. I think it's building on that area of we don't always know what people need or want, so actually come forward to us with a proposal. There is a degree of governance there, as you would expect. This is public money, but actually at a probably slightly lower level than normal that allows people to take a little bit of a punt and do that. So say the last round we did £160,000 into children and young people. We run that again, and we will run it again later in this year around themes that people tell us are important. So the idea being that it just allows some of those smaller providers to get involved in it in the same way as some of the big people on the patch.
Be useful to see what sort of projects you have funded. If you could let the chairman have that and maybe have a look at what has been done with it and when your next funding rounds are going to be happening, because I do think it's not something which is widely known about, and it would be very sad if projects which have been going for nigh on 20 years end up folding because they can't continue for lack of funding.
And sorry, Nicola.
I was going to say we can certainly share that information out. Just in addition, you know, we have invested in a role within Support Staffordshire, specifically around mental health, to do that sort of engagement with us around the voluntary community sector, and they have regular forums. So we are making efforts to get that information out there as much as possible, but always aware we can do more. So certainly can share that information.
And I think that Support Staffordshire has had some funding in terms of social prescribers. I don't know if that's still rolling. I seem to think we've not really talked about additional investment into schools, but there has been additional mental health investment into schools. But I think you were specifically talking about voluntary sector and communities, so maybe that's off that. The other bit that I wanted just to reflect was in terms of page 35, the two actions. I think they're blank because not because they're not important. It's just that the future actions, the work is already ongoing as part of the action plan earlier in the document. Maybe Jan can just confirm that's the case.
Yes,
rather than no actions.
Yeah, that I could probably word that to make that clearer. So yes, the table below are just actions that we've identified that are coming up. So there aren't necessarily actions against each one because they're future actions. For the outcome of 2 and 3, there's quite a number of actions already in progress and identified in the actual draft action plan. It's just that at this point there aren't future ones as yet that I've sort of identified for those outcomes. But there may well be in the future additional ones to come through.
So there's a worrying discrepancy between the performance of some of our NHS trusts, whether it be combined healthcare or whether it be the Midlands Partnership Trust. And, you know, it would be useful to know whether any of that is related to financial implications or whether it's, you know, an issue of performance within the trust. Because, you know, we're coming on to that, but clearly where there are such significant discrepancies, questions have to be asked about why that's happening.
So you're doing a Keith and taking us to the next point on the agenda. So I'm going to hold that question if we can, because you're going to re-ask it when we do get to that point on the agenda. Anne wants to come in on something very linked to this.
Yes, thank you, Chairman. Just to pick up on Charlotte's point, actually, about the money situation. To be fair to Community Foundation, they've actually put that out to the community. I've already signposted 2 of my voluntary organisations to it to apply for funding. Thank you.
Thank you, and obviously members may choose to circulate those details next time they come around more widely. Before I bring in John, I'm just going to bring in Bernard, because then we'll have done everyone first time round.
Thank you, Chair. I wonder if I could just move the conversation along to the paragraphs that discuss race. I'm from Burton-on-Trent, East Staffordshire, and we have a very diverse community in East Staffordshire. And I'm concerned there's plenty of mention of cultural and recognising cultural needs. One of the big things in that environment is trust. So would you be able to summarise back to me what you're doing in East Staffordshire and Burton under the heading of race to engage, seek further feedback? So you have feedback, do you? So what will the benefit of further feedback?
Thank you, the elected member. Nicola probably may want to come in on the NHS, and Sarah, my colleague in public health, we may support on this one. So in terms of this, for me, sits in the outcome really, which is about equal access, because one of the things again that came up in the engagement is sort of the health inequalities of people, and that would include people, ethnic minorities. We did, in terms of e-staffs, we did do some work in developing the strategy with the Community Champions programme, which the first one they had was Burton, and the members of the Burton Community Champions, mental health was one of the priorities they'd identified, and I attended those meetings in the development of the strategy. So that certainly fed into this. Again, where I am personally now with this is that then we'll be reinvigorating some of those contacts and engagement. I know my colleague in public health, Sarah, is covering today. He's on leave, so she may not know. But certainly there's within the actions around, there's some work that's being done specifically in Burton around suicide prevention around in the staff's area. And that is, I don't know whether, I'm not sure whether Sarah would know more to comment on that one. So I think there is, certainly from a personal perspective in my day job, I am a lead in commissioning around mental health. And I've had specific meetings and discussions with colleagues in MPFT around concerns around support for people with mental health problems in e-staffs. And we've got one or two specific services that we use quite a bit that are culturally appropriate. And we've linked in a number of areas where we're recommissioning, where there's an opportunity for us to influence that. So I would think that will be reflective in some of the wider actions there around recommissioning of things like residential nursing care, supported living. So those should take into account equality, diversity, inclusivity elements within those recommissioning as standards. So I think there'll be a number of pieces of work in the action plan where that will be something that we'd pick up. But certainly personally, I have had a number of conversations, particularly around the e-staffs area, recognising that is a particularly diverse area of the county, and acknowledge that. Nicola, I don't know whether there's anything you want to come in from a NHS perspective.
So inequalities is a huge sort of item for us within the NHS and the ICB, and recognising obviously that we need to do more. And I think it was incredibly highlighted during the COVID period, wasn't it? And that's where the momentum sort of come from. So within mental health, what we've been trying to do is what's called the HEAT tools, which is health equity action sort of tools, where we look in very specific areas and look at what the communities make up as there in terms of how we need to respond, what their priorities are. And we've very much been working very closely with the district and borough councils in terms of looking at, and I know there has been that work done in East Staffordshire, and very much the sort of grant process that Ben referred to, the MPFT have looked at, has again been trying to target some of those communities, recognising that people with black and minority ethnic backgrounds are still underrepresented in our services. So it's what can we do more of to make sure that people are getting the access when they need it, all that sort of preventative help as well. So there's work ongoing, but again, it's an agenda where we've got a lot more to do, and it needs that more. We need to have that collective response, really. So that's very much about how we work in those specific neighbourhoods to make that difference to that population.
Bernard, do you want to come back?
Yes, just a couple of points, if I may. I picked up on a phrase you used there. There's a lot more to do. And I'm just anxious, and I wonder whether there's any clarity around what sort of timeline, because suicide prevention or any of the topics we're talking about won't wait until you've got your act together, if I could put it that way. So is there a sense of pace? I'm looking for that feeling in what you said, and I haven't got it. But what I have got is a sense that the pathways are clear, but progress isn't that quick. And is that to do with workforce? What are the challenges around that point that I've just made?
I think it's multifaceted. So I think the communities across Staffordshire are very different, and the community in East Staffordshire is very different, obviously, to some of our other populations in Staffordshire and Stoke, for example, where we have high levels of black and ethnic minority communities in place. In terms of pace, what we've described within the action plan is very much about delivery. So very much the Community Mental Health Transformation Programme is a live programme that we're actively delivering upon. Some of the crisis responsibilities, again, that is an active programme that we're delivering upon. I think what I'm sort of referring to is, in order to really meet that sort of inequalities agenda, it isn't just about mental health provision acting on its own. It's got to be that wider collective response in terms of how we do something differently for those communities. So how that works across primary care, mental health, all social care, all sorts of other different provision in terms of how we take a different approach. And that doesn't just sit within the mental health services that we have. We have a responsibility, absolutely, to do things differently and make sure that we're doing everything we can to reduce any barriers to access, and that is ongoing. And there's lots of work within MPFT, particularly around diversity, that colleagues within MPFT will be able to speak about in a lot more detail and with a lot more articulately than I can. So we can certainly take that back and look at the specific programmes that we could give you detail on that are doing some of that work.
Can I just bring in Julia?
Yes, thank you very much, Chairman. I think it's relevant to point out to members that as part of this workforce plan, there is the community impact assessment, which always ends up being a detailed document at the end of every report, which perhaps not everybody gets down to. But on page 41, there is a section on race, and within that, there is quite a detailed section on the mitigations. And it identifies that there's a range of engagement activities already taking place, that further feedback, because it's that ongoing process, will take place. It's developing the workforce so that they recognise the differing needs, and it reflects in the work that they do, and organisations providing services, identifying training and development needs. So I think it is a really important section that we have to recognise that, with certainly with, say the Ukrainians as well, they're throughout the county, as are other people who have come to this country, that actually this is a piece of work that feeds into everything we do. So Bernard is quite right to identify it, but I did want to just raise people's awareness of that section within that community impact assessment.
Thank you. I did note that the community impact assessment was 25 pages long and the action plan was only 11 pages long. I did note that. Let me
can I briefly come back to that, Chairman, because you've made a number of comments. And when this strategy was being developed, I gave Jan a really hard time because I said strategies should be no more than 6 pages long because they become so wordy, so complicated, they're unmanageable. And bless her, we got to 8 pages, but she did identify that included photographs.
Thank you. Bernard, is there anything you wanted to come back on? Apart from you were clearly going to volunteer any assistance that people might need to access various groups in those communities.
Exactly right, Chair, and thank you for preempting that comment. Thank you for that update. The challenge is immense, I would suggest, and well, I wish you well, because as I've said, there's no time to dwell. So there's so many. I mean, the amount of, I'll try to add up the names in the action plan, the amount of people playing in this at the moment. Sorry, I didn't mean playing. The amount of people involved with this. How the heck is it joined up? Where is the pulling together of it all? This is the classic program management routine. There are so many projects going on here. Who's got the overall strategic view? So I look forward to hearing from Julia at some point exactly what progress is being made, and as I say, best of luck.
So we're going to do a whistle stop around the room. Chris, then Julia, then Anne.
Yeah, and I'll be brief, Chair, but just on that wider point around health inequalities and joining things up, very conscious we're having a focused conversation on mental health. But if you briefly go back to the core purpose of integrated care boards, they were set up with 4 main aims, really. The first 2 of which is to use population health management techniques to reduce health inequalities, and I think both of those are very apposite to the question that the councillor raised, and therefore it is more than a mental health conversation. It essentially goes, as I say, to the core purpose of the ICB, and at risk of mixing my plosives, we've been working at integrated care partnership level, so ICP, to set out that kind of overarching strategy, which provides that context for then how do we start a conversation about health inequalities using PHM at that neighbourhood level, so we can really start to understand not just the what in terms of the health inequalities, because we've kind of known about those for some time, but more so about the why. So challenges around things like obesity levels, suicide rates, etc. They may be comparable in different areas of our geography, but sometimes the drivers or the determinants of those are different, and therefore the response to those needs to be tailored slightly differently. But it's only when we're able to kind of enrich ourselves with more understanding than perhaps we've got at the moment that we're able to bring forward those kind of tailored interventions. So there is a much wider programme of work that sits behind all of that.
Chairman, I mean, obviously the Integrated Care Board, obviously the scrutiny that has a role in holding those numbers of people and the whole plan to account. But of course this is why the Health and Wellbeing Board has taken the approach that it has to have each quarter a specific target. And being the Vice Chairman of that board and somebody who's very keen on performance management, and I don't like red items on my watch, it is for us collectively, and I would implore those particularly districts and boroughs who are part of that Health and Wellbeing Board and other partners to actually offer that challenge. I'm a great believer that reports should be honest and specific. Cut out the woolly words. Where we've made good progress, great. Where we haven't, be honest about it, because then people, you know, have to make decisions as to, well, do we change that tack? So I think we all have that collective responsibility to make sure that the action plans deliver the strategy and deliver the improvements for people out there who we serve.
Thanks. Anne, did you want to come in on this specific?
I just wanted to mention, thank you, Chairman, I just wanted to mention in the last couple of conversations, we've mentioned suicide, and it's something we've not really talked about this morning. And I would be interested to know what work Chris Stanley is now doing. Probably Jan might be able to answer this. Give a little brief overview of what the work Chris is doing about suicide, because I know there's a lot of work going off in the background. Can I just finish by saying, we've talked a lot about mental health and about people, older generation with mental health, but I still come back to my main point. If we help these children right at the beginning, we might not have a lot of these problems as they go on in life. Thank you.
So let's go back to Bernard, because it was Bernard's sort of area, and let's stick with that, please. So Bernard, do you want just to...
I don't think there's much more to say. Anna's just prompted me to say something, and I'm a diabetic. And the incidence of depression and anxiety within the diabetic community is significant and increasing. And it's probably the same with anyone with a chronic illness. Managing the unknown, mental illness follows that. So that just emphasises the point I was making, really, about pace. And it's all about, I hate to use this phrase, educate and inform people. But are they listening? That's the challenge I have when I'm talking to colleagues and friends who are diabetics. They can hear you, but they're not listening. And I do hope that you don't find yourself in that predicament. Thank you.
Thank you, Bernard. And maybe part of the answer with some of the partners who aren't as engaged as they could be is to be very demanding of them in terms of what your expectation is from them. Because that is one way of at least... deciding whether they're on the bus or not, and sometimes that needs calling out. Can we go on to Anne's question about suicide? Who wants just to pick up a very brief overview, because we could fill an hour or two on suicide, and that wasn't on today's agenda either. So just a very brief part, please.
If I can just say, Chris Stanley's on leave today, unfortunately. Sarah Tunnicliffe, she's a colleague of Chris's, so I'm just going to hand over to Sarah to give a very brief update, if you could, Sarah, on where you are currently with the work Public Health doing on suicide prevention.
Yeah, I'll do my best in Chris's absence. So one of the big things that we're working on at the moment, we have commissioned and are now, well, we've just gone through the tendering process for a provider for our postvention service, which is suicide bereavement service, so specific to those bereaved by suicide. So that will hopefully be launching, well, it will be launching towards the end of the year. We have now a new RTSS officer in place. That's the real-time suspected suicide surveillance officer. So we're going to be establishing a more focused working group around the information that we get from the RTS, so that we can focus our work around priority sites and any new and emerging methods, any potential clusters, anything like that. So we're going to be focusing more on that. We have an ongoing programme of training that we commission, for suicide awareness and prevention training. We've now had approaching 3,000 people who have attended that training. It's very well received, very well evaluated, and we're now looking at developing that with the trainer to be more specific to people working with children and young people, because that's come out of the feedback from it a lot, that the way that the people working with children and young people approach people with suicidal thoughts or ideation is different. There's different things to consider. So we're hoping also that will be ready to launch by the end of the year or beginning of next year. It's just going through some work at the moment. And we're also going to be looking at work around that course and adapting it hopefully for people in Gypsy, Roma and Traveller communities, because that's another area that we need to do some work in, another target group. I hope that's helpful.
Thank you, Anne. Thank you. And finally, John.
Sorry, it's all right, Chair, the moment's passed. Thank you.
I do apologise. Right, okay. Just two things in the back of my mind just sort of nagging slightly. I think this is a very comprehensive document and covers a lot of strands, as members have indicated, of activity. And clearly there's a lot of work to be done as well at the same stage. I do like the actions, but I guess my only slight sort of nervousness is, are they smart actions? You know, and maybe this is just me being hypercritical, because it probably is. But when it says things like grow the CAMS workforce, you know, from what to what by when. Now, I've got the when, because we've got the March 24, and there probably is another column that we just haven't seen, which has got the very specific bit to it. But, you know, if I was writing an action plan, that's probably where I'd have it. And the bit, and I say, it's me being hypercritical, so please don't take it any other way. But, you know, if I was doing an action plan, I would definitely have them as being smart. And you can say that many of them aren't smart, and that's probably because it would increase the size of this document significantly, probably. The other bit was being a bit of a nerd in terms of process and how things flow. Sometimes it's great to have the strategy, a gap analysis, and then the action plan, because you can see exactly why and where and how big and how, you know, where the urgent priorities are that come from it very easily. And there probably is a gap analysis somewhere that has been done to be able to create this action plan. And it would have been maybe interesting to have seen it, because I think it would have given a size and scale, which I think a number of members have talked about. So again, that's probably me being hypercritical. I don't respond to those, because I'll just wrap up the session if I can, however. I think the fact that this is co-produced across many partners and across whole life and includes people with lived strategy is really to be welcomed, and I think that is one of the things that sets this strategy apart. You know, we've previously seen lots of individuals come and talk at Scrutiny, and they come and talk about one subsection of something, and you know, it's very difficult to get it to see how it all puts together. So the fact that there is one document and it's bought into by all partners, I think is really to be welcomed, and clearly committee feel the same. I think, and clearly there's a significant amount of collaboration which has gone across partners, and I think that again is to be welcomed. I think it's brave in part by indicating the future actions that you're not working on today, but you recognise need to be done. So I think there is a lot of bravery in what is in here, as well as with the aspirations that members have indicated. I think it's really important to move towards that sort of parity of a stream, but the other element is it actually is very comprehensive. So I think we came up with a couple of suggestions outside of, in terms of the summary ones. One is to bring you back to talk at some stage about the community mental health and what is actually going on specifically there. Maybe a couple of, maybe the two providers could come along and just give us that sort of insight later in the year. I think there was a recommendation in terms of trying to share this strategy and action plan as widely as possible and be very specific about the asks. I think there was some very good suggestions in terms of the Stafford Connects side of things as well. But otherwise, I think it was a very useful session. Is there anything else that committee feel we should add in terms of recommendations for this morning's element? No? Then let us thank you all. If you're not involved in the next part of the agenda, you're more than welcome to leave. Thank you for your input. Jan, Nicola, Becky, Sarah, Julia, Chris, and a few others, no doubt. So thank you for that. And let's move on to item 5 of the agenda, which is the mental health performance, which I think is a really nice tie to what we've just been through, because actually, you know, we'll see the results come through in the figures, and actually seeing the figures, I think, is really important. So I'm now on page 63 of the agenda. Who is going to... Chris is going to lead us through this. We're with you. 5 or 10 minutes maybe as an introduction?
Yeah, probably less than that, Chair, if that's okay. So, as I understand it, there's some context here, which is that I think the committee may have reviewed quality accounts of both NHS providers recently, and that's led to an inquiry around perhaps differences in performance between those two providers. So just by way of contextualising that, the performance that we've shared then is predominantly about the performance of the two NHS providers, recognising that other organisations absolutely have a role to play in the provision of mental health services, notably colleagues in the voluntary community sector. There are a range of support services that are delivered through general practice as well. But given the context, we've focused this particularly on the two NHS providers. They are, of course, North Staff's combined healthcare, who provide mental health services, amongst others, in North Staffordshire and Stoke-on-Trent. And then Midlands Partnership University Foundation Trust, if I've got that acronym in the right order now, who provide mental health services, again, amongst others, in South Staffordshire, but also for integrated care systems beyond Staffordshire and Stoke-on-Trent. And both of those geographical points are important when we get into some of the detail around the performance figures. So in terms of those two organisations, they're both long-standing, they'll both have their different cultures, their styles, and they'll respond to different issues in their patient profile in the geographies that they support. And the role of the ICS, or the ICB, sorry, isn't to harmonise provision in that respect. We want those organisations to thrive and to flourish, but we're not going to tell them how to deliver the services. The skills, knowledge, the expertise around service provision sits within those providers themselves. But we do want to work alongside those providers to help coordinate delivery of services. So recognising there are differences in style and approach in terms of the operating environment, there is a reasonably consistent policy environment, and we play some of that out in the covering report. So we reference, for example, the 5-year forward view from 2016, the NHS long-term plan from 2019. If you translate that then into more local strategies, we've got the joint forward plan that was published earlier this year, and then of course we've heard this morning about the mental health strategy and the implementation and delivery plan that sits around that. And they are designed to develop a consistent approach or a consistent ambition across a shared set of priorities, and we've spoke about some of those this morning. That might be severe mental illness, it might be to reduce the number of inappropriate out-of-area placements so that patients get the support they need as close to home as possible, or it might be about access to talking therapies. And there's about 5 or 6 of those national metrics that we coordinate the delivery through via the Mental Health Portfolio Board, and Nikki spoke about that earlier in the previous item, so I won't go back through that again. But beyond those kind of national headlines, there are a series of other performance metrics, and we've provided a kind of sample of some of those to you in the appendix. And I'm sure there'll be a lot of questions that arise from that. But we often, just again to contextualise some of that data, we often hear about parity of esteem when we're talking about mental health services, so the need to catch up effectively from a mental health perspective to be equivalent with physical health services. And one of the many ways in which that manifests itself is in availability of data. So some of the data that we have available to us isn't as rich, it isn't as crisp, it isn't as focused as perhaps it is for, say, acute hospital care. And you'll see that come through. So there are some caveats that we want to share just at the headline level, because it'll avoid us repeating those caveats, I think, as we get into the questions. So often the data that we've got available to us is at provider level. So as I say, combined provide services across Stoke and North Staffordshire, MPUFT, provide services beyond Staffordshire and Stoke boundaries, and sometimes that is a limitation within the data. I think one of the councillors referenced that point earlier, that we know what's happening at provider level, not necessarily district, borough or locality level. There's often little in the way of benchmarking, because the information again is produced at provider level as opposed to geography level, and not every metric has a hard national target attached to it. So some of the data that we provide is more gives us a guide as a line of inquiry for questioning, rather than enabling kind of traditional hard-line performance management, as it were. And again, some of that will come out, no doubt, under the questions that colleagues have. And again, with that in mind, we've not necessarily provided a full suite of all the information we've got available to us, but just enough, we think, to kind of illustrate the point and show that there is divergence across the two providers, but actually understanding why some of that is the case is perhaps more the important element, rather than the headline performance metrics themselves. So hopefully that contextualises some of that. As I say, we've provided quite a bit of performance information, which no doubt colleagues will have some questions about. And I'm going to say predominantly Nikki, because Nikki's the expert in mental health performance from an ICB perspective, but no doubt at points Ben or Lisa may want to come in as well. But just as opening remarks, hope that's helpful, Chair, to contextualise some of the debate we're about to have.
Chris, that's really helpful, and you make some really good points, and I think, let me just amplify a couple of those. So I should just say that Chris and Nikki are from the Commissioners of Services, just so we're all clear in the room, and obviously Ben and Lisa are from the providers, North Staffs Combined and Midlands Partnership Foundation University Trust. This session really came out of the quality accounts, where we compared and contrasted for those people who were with us. And we wanted to ensure that whilst there was a difference in approach, a very clear difference in approach, we wanted to make sure that we'd compared and contrasted the two. Apologies that we lost the site visits that we were going to do last week. We'll get them back in later on in the year. But it will just continue that piece of scrutiny. But in some ways, it's about making sure the services are equally available to all of our residents, whether they're supported by North Staffs Combined or Midlands Partnership Foundation Trust. So that was the purpose of bringing this item together today. Keith, do you want to ask your original question, and then we'll go to Charlotte and she can ask hers?
Well, it was me that made the comments earlier about the districts and everything else, so I just thought I'd follow up on that because it was mentioned in the intro. Right data, right indicator would be, what I would suggest we do at the moment. And I know there's been, was there a breach of data and things like that as well? I think I read at some point. I don't know whether that's something that has been a problem, but I do think that is this in its infancy, because some of the data I don't see as being necessarily that helpful at the moment. An example would be in June for the CAMS weights, why suddenly those will drop off by half, from 34 down to 17.3%. There must be a reason for that. I can't see any change in the service in that 1 month. So I think there's an awful lot of interpretation that needs to go. And my only real comment was that, seeing as that we're now looking at the action plan, which we've just extensively looked at, is there going to be an update on these particular data, set of data that we're now looking at, and will it be brought together into one? I know that they're over many different areas and everything else like that. I think for us to spend all the time going into each one of these areas, looking at that's something that's probably potentially beyond the scope of this council, though obviously of this committee rather. But certainly that's something that I would like to see, something that's a bit more interpretable. Does that make sense? Because I think that some of these at the moment, I just don't think necessarily they look like they're work in hand, as it were. They don't look like the finished article. So I just want to find out whether that's the case or not, or whether I've misread some of the information, etc. Thank you.
Nicola, and also maybe we could answer the question at the same stage in terms of, if you can't do Staffordshire data today, is that an aspiration in the future?
So the data that's been provided is a mixture of what we have in provider contract reports and some indicators that we submit via our national data set, which is the mental health minimum data set. You have got a very small snapshot here in terms of those figures, so I'd absolutely take your point on that trend. We do have that information obviously available retrospectively for last year, and obviously we have more data available this year. Particularly with the mental health data set, there is actually a 3-month lag in terms of the data. So that's one of the challenges that we have. They are working to improve that, and I think hopefully by the end of the year that will go down to 2 months, but that still is a data lag, which I absolutely take your point on, and has been raised by our chief exec sponsor as an area as well of focus, because looking at the data 3 months late, sometimes we could have intervened to do something earlier. Yeah, which is why we look at the provider contract reports as well, because they have that live data. What we do have in place is a more comprehensive dashboard of mental health indicators that cover a whole range that we can share with the committee as well. So that covers both, we have one for mental health and we have one for learning disability and autism. And some of those figures we are able to do at a place level. So we can split Staffordshire and Stoke. But in terms of some of the district levels, that is potentially a manual sort of audit that we'd have to ask both trusts to run. So I think what we'd need to be clear about in terms of the action plan that we've just spoke about is where members think the most value would come from splitting those metrics at that level, and then to see if actually we could work with Lisa and Ben to see actually if that's possible in terms of how we can do that moving forward. But yes, take your point on the limitation of what's been presented today. It just gives you a flavour of what we can do, but there is a more comprehensive dashboard that we can share with you. Chris.
And to an extent, I think it goes back to the kind of the opening remarks, just in terms of setting that context. So they're not kind of work in progress necessarily, but they are probably more a limitation of the fact that the data that's available to us in the way that Nikki's described just isn't comparable to some of the really hard, crisp, focused information that we have for some of our healthcare services, and that's part of the national performance environment rather than something that we can influence locally at ICB level. Equally, it's not a new thing as a consequence of the ICB, the clinical commissioning groups, primary care trusts before them have all kind of experienced the same challenges. So within that context, I guess we then need to think about, so what's the purpose of performance management information? And to a certain extent, whether it's a 3-month lag or a 6-month lag, it tells you what was happening some time ago, whether that's a number of weeks or a number of months. And that's useful to an extent, but by default, it's a rear view mirror onto performance that was happening, if we sat here in September, in August or July or June. The important bit for us as an ICB then is to foster relationships with colleagues at Combined and colleagues at MPFT, so that we're not going to them in 3 months' time to say what was happening in June. They're able to come to us in June and say, there's an issue going on here and we just need to have a conversation about it.
Yeah, my concern really is about the fact that we've just said that what we've all said is a very decent action plan. And it's being driven by, the new ICB and the partnership work and everything else. And I'm concerned that for little tiny bits and pieces of info and things like that, it doesn't seem to be that there's a potential way of actually seeing how well that action plan might actually start having an effect. And that's the reason why we're sitting here as a committee, from the council, is to be able to report back to people and to have that scrutiny about those things. So if we don't have the tools in which we can do it, I do think this is something, Chair, that we do need to have a bit more of a handle on as time goes on, not just necessarily mental health. I realise that the other big issue that we have with the NHS in particular is that the county borders are non-existent in many of the services that you provide. I mean, I've gone to Derby, Lichfield, I've gone to all these other places to get some work done, from myself. So it's something that if I'm struggling to get a handle on it, then I think others might be as well. This Chair knows a bit of a data boffin in terms of trying to find out how things are working. And I think he's one as well, to be honest, so I think he'll probably have the same comments as well. I know it sounds strange. Is there a plan to get the plan for the data better? I think that would be my final question. Thank you.
So there is certainly work we are doing to understand, to get beneath some of the challenge. So as I say, we're very much aware that the landscape of provision across Staffordshire and Stoke-on-Trent is predominantly through two statutory NHS partners, but not exclusively. And therefore, the information that we get through those, the kind of national minimum data set, etc., is representative, but it's not the full story, because not all of that pattern of provision is being reflected in there. So there is work for us to do to set up some local systems, make sure that within, say, the Community Mental Health Transformation Programme, where services are being subcontracted through NHS partners to the local voluntary sector services, the right data capturing arrangements are in place. So, yes, there is work to be done. However, I guess I just want to clarify again that we are working with some national policy limitations in terms of the national minimum data set, what that includes, what it requires trusts to provide, and then some of the data capture challenges around that. So we're augmenting at local level, but there is a context in which we work, which again is why the important factor for us is about building those positive relationships with colleagues, so we can self-improve as a system rather than rely on data to kind of tell us where we were in hindsight some weeks ago.
Thanks, Nat. Keith wants to understand the timescale. Apparently, I'm asking his questions for him now.
What timescale have we got before we can start then using these to be able to see how well the action plan is in fact hopefully coming along, over the coming months and years?
Can I pick up on that? Because I think if we're not careful, we'll sort of misread the purpose of the report that's in here. It wasn't put in here to support the action plan and give metrics against the action plan. It was to compare and contrast the two operating organisations and to ensure that the services our residents were receiving, whether they had them from North Staffs Combined or from Midland Partnership Foundation Trust, were the same. So that was the purpose, and it feels like we've confused. And I think the answer to your question, Keith, is the 2 points I made right at the end of the first session, which was, the action plan needs to be smart, because we can then measure it. It either did happen or it didn't. And second of all, we needed to see the gap analysis, because if we saw the gap analysis going smaller, then we would know that we were going in the right direction. So that would be my view. Just in answer to a couple of other things. One is, I think we've got to be careful not to duplicate what the ICS board does, because that is outside of, that's their job and that's outside of our remit. I think we should be asking for Staffordshire stats from the ICS. I think to ask them to go and do it for district probably overcomplicates things, but I think certainly we should be asking for Staffordshire stats, because that's what we're interested in, no disrespect to Stoke-on-Trent. And it is important we do get a working dashboard. It still is work in progress. It gets a bit closer each time, but it feels like painting the Forth Road Bridge. We do need to get there, though, and I do take that point. Charlotte Atkins.
Thank you, Chair. I mean, looking at your trust comparison, it looks as if there's a very distinct difference of performance between the Midlands Partnership and combined healthcare. If that is correct, why is that, and what have you done to investigate the reasons behind it and to mitigate that difference in performance?
Who's picking that up? Bless you.
Is there a specific example you wanted to look at, wanted to focus on?
So I was looking at eating disorder weights, CAMS, out-of-area placements.
Yeah. So in terms of there are differences in performance. So again, one of the things that happens is we're scrutinised monthly by NHSE in terms of some of this performance. So we have to put in explanations to look at this. The eating disorders is actually one of the national metrics, and the difference in performance is down at the moment to the workforce that's in place to deliver against that. So there's been specific issues in recruiting to posts within the MPFT service, particularly around medic input and dietetic input, which has meant that performance is different. That has been an improving picture. Obviously, we've got a plan in place with MPFT in terms of recruitment to those roles to get it up to full establishment, because it is funded to full establishment. But things like that particular one is down to the availability of workforce. In relation to adult out of area placements, for example, the ambition is 0 for that. We have been meeting that ambition for quite some time, but we've obviously recently had particular spikes in acuity, and also a number of changes within the secure estate, which has meant patients that potentially were admitted within secure estate are now being required to be admitted locally with our provision. So that has meant some placements have had to go out of area. The important thing to note there is that we repatriate those people back into Staffordshire and Stoke-on-Trent as quickly as possible. So a lot of that is around PQ access. So there are variances in performances, but again, that's part of the assurance process that we have in place with NHSC and the providers to look at that and look at what the mitigations are for that, and actually what are the improvements that we then need to make moving forward.
So what is happening with the workforce issues? Are they now resolved, or are we going to see similar figures to this for the next round of statistics? And if it's not being improved, then clearly these weights are impacting significantly on patients, and surely that should mean that those patients should be directed elsewhere if those targets can't be met.
So in terms of the workforce, so for example with the CYP eating disorders, as I say, we've got a plan in place for that to be fully established and recruited to. Obviously workforce is April was the date for the medic, which was the challenging post that we had to recruit to. What we do obviously work with providers is to make sure that they are able to access other staff to temporarily fill some of those posts in that activity. And what we also see, if that specific one around eating disorders, is what we see as exception reports against those breaches. So what we're talking about here is really small numbers. So you're talking about 2 or 3 patients that cause that breach. So although the number looks significant, it's 2 or 3 patients that are causing that figure to miss the target. So what we do is we look at the exception reports behind those patients from a quality perspective to ensure that there's been no harm to that patient. And invariably when we look at the exception reports for CYP eating disorder, for example, some of it's around patient choice. The family have wanted to change the appointment date, etc. More likely it's due to having a joint appointment with the Children and Young People's Eating Disorder Specialist and the CAMS specialist, which is in the best interest of the child, so the child doesn't have to have 2 assessments, if that makes sense. So we're doing a holistic assessment and then making sure the child gets put on the pathway that's best for them, be that the eating disorder one or the children's mental health one. So there's quite a bit of context behind each of them in terms of explanation.
Are you expecting the performance in future to be very similar?
We're expecting an improved position. That is the plan, to make that position improved. But obviously we have to work closely with our provider to agree what that date is and when that will be achieved. And with things, we are talking about a very specialist workforce, in particular with children and young people's eating disorder provision. So if we have workforce that happens, and it has been not unfortunate for the people, but they've gone on maternity leave, that does have implications, and then it's trying to backfill some of those staff. So again, it's something that we assure ourselves through the ICB. We have NHSC assurance meetings that again look at that and scrutinise us, and we submit plans to them to in terms of how we will address that. But it is an improving position we want to see. But I can't give you an exact date on that at this point in time.
Can I bring in Chris?
Just on a more general point, if I may, Chair, about how kind of performance management in the NHS, because I think a colleague made the point about not kind of duplicating the work. So this applies to much broader than mental health, although it includes mental health. So you've essentially got a kind of tripartite performance management arrangement. There's obviously the organisational specific performance management arrangement. So the two provider organisations will have their own performance management processes as part of their own kind of decision-making arrangements. From an ICB perspective, then all the what's called the NHS oversight framework measures, which includes about 5 or 6 mental health specific measures, are reported to the Finance and Performance Committee on a monthly basis and included in the performance report that goes to the ICB board on a monthly basis. And then, as Nikki says, the arrangements of NHS England, which have changed with the advent of the ICBs relative to clinical commissioning groups. NHS England now have an operating model which says they work with and through the ICBs to manage performance at more local level. And what that means in practice is there's a quarterly session with NHS England colleagues called a quarterly system review meeting, where again they go through a number of issues, including the 5 or 6 kind of national metrics around mental health. But then they would also, subject to a kind of segmentation process, that expect, and we do, the ICB to have provider-specific meetings with both MP, UFT and combined healthcare separately on any issues that are relevant to them as an individual provider. So as I say, there's quite a complicated on sometimes set of performance management arrangements, but all those metrics are included within the scope of those arrangements.
Thank you. Charlotte? Can I just ask one on this? Because, you know, in some cases, the performance is significantly different between the two providers based on the figures, and the figures may not be reality. But if I was a Staffordshire resident, you know, I might want to go to the faster one, particularly if they're not within the 4-week referral period. You know, have you got a more dynamic way of getting people to access the fastest system or the best system?
At the moment, the way that the provider contracts work is North Staff's combined healthcare are commissioned for populations in Newcastle, Staffordshire Moorlands and Stoke-on-Trent to access, and MPFT for Stafford, Borough, Tamworth, Lichfield District, East Staffs, South Staffs, Cannock Chase residents to access. So that's the way that it's established at the minute. We do have some provision in place where we have a sort of prime provider model. So for example, with talking therapies, and we have been able to move workforce around to a degree in some of those provision to meet need. But on the whole, the expectation is the providers meet the service requirements of their residents in the areas that they're commissioned for. And obviously that's why we work really hard to make sure that our residents have that same sort of level of access, experience and outcome, recognising that there can be variation in delivery models, but that's where we're focused on. So, but again, some of the provider report measurements or contracts in terms of how the metrics constructed can vary slightly. So again, we just need to do a piece of work around data quality, in the sense that, are we really comparing? It looks like we're comparing apples and apples, but are we really? And I think that's the piece of work that we need to do in terms of data quality improvement.
Yeah, and I think you highlight exactly where our concern was, and I'm not convinced that they do tell us the same thing, but it does surprise me somewhat. I mean, I heard your answer and understand the answer, but it does surprise me that in the first 2 hours of the discussion on mental health, very specifically, we were very complimentary, I think, about co-production and about collaboration. And actually, maybe the providers should be collaborating to make sure that the residents get the best deal for Staffordshire. and maybe I'll leave that just on the table as a suggestion that, you know, you both, if the ICS framework doesn't allow for it, but the providers actually can choose to do something different if they want to make the journey of the Staffordshire resident better. Janice.
Chair, there's literally words just being taken straight off my page, actually, but I appreciate you can't see them. But, are we comparing apples with apples? And the data validity, for me, was probably the most striking part, because we can draw out some significant inferences. What we've been asked to look at is, or the statement in this particular report is along the lines of an equitable service provision. And then we look further down, and one of them's rated 1 out of 56, and the other one's 22nd out of 56. My conclusion to that is that it's not equitable. And I would be, as the chair's just said, if I was in that position, looking at how I can possibly access number 1 out of 56 as opposed to the 22nd. So I think in terms of the data validity, and I appreciate the caveats were in there, if we are sort of encouraged to make those conclusions, that we need to be able to do so with fair data. And I'm not sure if that is where we're at now, but I appreciate my colleagues also asked about the plans to enhance that in future, and I think Chair's made that statement. That probably the one that jumped off the page for me, and I think that we also picked it up earlier on, was the inappropriate adult acute mental health out of area placement. We've got huge variance in those ones, but I believe it brings in another ICB as well in that data. So that's why I'm thinking we need to make sure we've got confidence in the data before we extrapolate what could be quite damning conclusions. If I could just have a reply to that one.
Nicola.
Yeah, so again, this is some of the constraints that Chris referred to earlier about the national data set. So for inappropriate out-of-area placements, it's trust-provided data, and MPU UFT don't just cover Staffordshire and Stoke-on-Trent ICB, they cover Shropshire, Telford and Wrekin ICB. So some of the data does pull that in, and that's what we have to sort of try and extricate. And obviously, we tried to do that in terms of that particular page, but you'll see there was a big number there associated with MPFT, but most of that activity is Shropshire, Telford and Wrekin, not Staffordshire and Stoke. But you're right, it's about the refinement of what we're presenting, so that you have that confidence in terms of the data. And like I say, there's still data quality improvement that we still need to do.
Janice.
Please come back. I appreciate this is a starting point, and you need that starting point, and then you can look at it. I think it's just exercising that caution at the moment from me as a committee member before we do start drawing out those conclusions that we are comparing apples with apples. Thank you.
Thank you. I've got no one else on this indicating. I think it's been a useful conversation because it was striking on the quality account presentations the differences between the two organisations, and both organisations, both providers are highly respected organisations in what they do. And so it was an important piece of work that we needed to do. I don't think we're at a conclusion by any amount of means on it, and I think we probably could be led a bit more in terms of what it tells us. So, for example, on page 68 on geography, I look at the number of referrals for children and young people, and actually it's very low in Stafford. Does that really tell me, given the population in Stafford is by far and away the largest of all of the districts and boroughs, does that tell me there's an underreporting, or does that just tell me that we have less incidence of mental health problems in children and young people? So I think it's been a useful discussion. I would propose to bring it to a close now, with the suggestion that we jointly behind the scenes do a bit more work, just to refine it and hopefully get it towards a Staffordshire piece of data, but also something where it is more reflective of actually the realities between the two organisations, because I think it is something that we need to assure ourselves on, given there is a clear difference between the two providers within the county of Staffordshire. Unless someone else has got anything else to add to that, I'm going to suggest we call a halt to that one. And thank you for the work that's gone in here. I know it's not complete, but I think it was an important debate to have, and we'll come back up again, no doubt. Thank you. Okay. So that brings us on to, you're welcome to stay, you're welcome to go. You're and we should thank you, yes, exactly right, thank you. Right, committee, let's just try and get the most out of the next few minutes. District and Borough Health Scrutiny Activity. We're on item 6, and pages 73 to 76 of the report. They are as they stand in front of you. The only thing I would ask, however, is do we know how many district and boroughs have signed off the new terms of reference? Zach?
Not definitely. We are due to have a health scrutiny officers group meeting. It's either next week or the week after. I think it's on the 19th, where that question will be asked.
Okay, maybe the district and borough and county members who are on the committee for the areas that haven't signed them off might be interested in knowing that, because I don't think we should just let this wander indefinitely. So maybe you could just write to the individuals concerned, your district or borough hasn't signed them off, and then at least we can try and move that to a conclusion. Thank you. I think I had Paula first and then John.
There we go, thank you. Yeah, well, I'm standing as a substitute for Councillor David Williams. His update to me, first of all, I should say that the terms of reference we did vote on at our last meeting and they were accepted. So that's Cannock sorted. The next meeting of the Cannock Chase Health, Wellbeing and Community Scrutiny Committee is on the 18th of September, which is next week. At that meeting, the committee will be receiving updates on the performance of the first quarter. The committee will also receive presentations on the Council's Environmental, Health and Public Protection Service and a presentation from Beat the Cold. A working group has also been formed and has met to review the letting standards of social housing, and we've begun its work programme. In addition to that, another working group is awaiting a presentation on sustainability at the council. All of these things, of course, are sort of healthy lifestyle, generate sort of better lifestyle for people in that context. Thank you.
Thank you, Paula. John?
Thank you, Chair. Yeah, I just wanted to put a little bit of flesh on my bit on page 75. It says about we did review the terms of reference, and I have to say nobody, almost unanimously, was very happy with it. We have reluctantly, I think, agreed to move with it for now, but particularly with regard to primary care and specifically ambulance, we're not very happy at all. And given the geography of the moorlands and the particular problems it's apparent that we're having with response times and to some extent public access defibrillators, we think that West Midlands Ambulance Service needs a little bit more attention, if you know what I mean, and local attention. We're going to discuss it again on our meeting on the 27th this month, but I think I'm quite fully expecting to be bringing along a request to this committee that Staffordshire Moorlands is allowed to lead somewhat on that particular aspect of ambulance cover, because we've had some very tragic incidents in the last year or so, well before that, but certainly in the last year or so, we've had some very highly detailed and specific incidents where they've not, the outcome has been probably better than it could have been. And I think to some extent, the ambulance service, the get out of jail card, free card seems to be it's hospital delays. Well, it may have been hospital delays. I don't think it's quite so much that now. It's more to do with the lack of resource in the rural communities. So, as I say, I may be bringing that along. We're going to discuss it again, and I'll keep you posted. I just want to give you a bit of a heads up on that, Chair. Thank you.
Thank you. Just in response, I know that you and Charlotte weren't with us for the first minute or two of the meeting. I met recently with the ambulance service and to talk about defibrillators. I was relatively happy with the answers that they gave. I was particularly unhappy with the answers they gave on performance. As such that I suggest that we bring them into committee as a dedicated session, I'm suggesting that we put in an additional meeting on the 13th of November, Monday the 13th of November, specifically to review the work of West Midlands Ambulance Service. I suggest that we keep the terms of reference to that meeting relatively specific. So there are specific areas like, for example, we've looked previously at first responders, and we should take an update in terms of that. We should look at Cat 2 response times, because I think that they are equally important as Cat 1s, because obviously the longer they go after that. We should give West Midlands Ambulance Service the opportunity to talk about some of the stuff that they're doing in terms of staff and recruitment, because I think some of the work they're doing is positive. So I think we should try and take a balanced approach to some of those, because there's some big issues, some big meaty issues, and I was not entirely convinced by a meeting I have to say. So I would suggest that we bring them into committee on the 13th of November. Are we in agreement with that course of action?
Yes.
Okay, thank you. Maybe you can reflect that back when you meet with your committee in a couple of weeks' time.
I think, Chair, to be fair to them, they're a bit better than they were, but they're diabolically poor compared to what they were 5 or 6 years ago when I worked for them. I'm not saying my departure started the rot, but when I see the response times now with what we were targeted with and what I was expected to do and what I had to account for if I was late, it's just chalk and cheese. We're talking about people waiting hours still for a fall and an hour for a stroke. And that's just, time is brain. That advert is right, time is brain. And now it's just not on. And for Anthony Marsh is on record as saying that they've never had the resource to give adequate cover in the rural areas, which is an absolute, well, I won't use the words, but it's not pucker, can I say. So they do need to be brought to account, and they've certainly got the staff, they've certainly got the vehicles. So I won't preempt that discussion, but it's certainly, and in the moorlands, given the geography, as I say, we do seem to have a particular problem. I mean, it's bad enough if you live in Leek. If you live in the hinterland of Longner or Flash, basically, if you have a cardiac arrest, mate, you're dead now. Whereas before, when there was vehicles in Leek, you did at least stand a chance. So I'll say no more. Thank you, Chair.
I mean, you make some really important points, and clearly rurality is going to be part of the discussion when we see them, because we are interested, I'm sure, in making sure that there is maybe not the equivalent service, because in a rural area you're never going to get the same service, but is the balance in the right place? And I think what you're indicating is that in the moorlands, in the rural areas, you don't feel that's the case, and that's a point we should be making. Okay, so can we just stick with item 6, which is district and borough updates? Any further updates?
Yes, Chairman.
Anne.
Thank you very much, Chairman. Just to quote on the 5th of September last week at Stafford Borough, just 2 items relating really to the borough. We discussed Freedom Leisure and how they operate, and we scrutinised that, and also the quarter performance report. I just wanted to bring that. Thank you.
Thank you, noted, and that's helpful. Thank you. Anyone else got any further updates? No? Okay, let's move on to item 7. We've talked about the work programme. What we haven't talked about so far is we held some recent meetings on Staffordshire Connects service, so thank you to those people who are actively involved with that discussion. I think that's now at a conclusion, and will certainly feed into the launch of that system formally early next year. In terms of the social care working group, the timescales for delivery of the specific actions on that working group have now moved out to being the end of the year, and as a result, nothing to report apart from that Richard Cox is going to chair the group, and that will start working formally from October onwards. And the 7 or 8 members on that working group have all taken a specialism in terms of looking at social care from the eyes of a specific area, whether it's the carers, whether it's the providers, or whether it's those seldom heard voices. So as a result, we'll report back when we have something to report back on. In terms of the Women's Working Group, I know that Janice is going to update us, maybe?
I am indeed. I was just sort of waving discreetly at you. So it's taking a bit of time, but I have actually now met with Dr. Lorna Clarkson, who's representative of the ICB as a women's representative, following on from the publication of the Women's Health Strategy as a national document. And fortuitously, there is already a report prepared which gives us the Staffordshire perspective on that. That's just been received, and I've asked Debs to circulate it amongst the members of the Women's Health Task Group, and then we shall be shortly having a meeting where we'll be able to look at that. So what I found particularly reassuring was the questions that we had asked from our initial meeting is what's actually answered in the report already. So the alignment between those I thought was absolutely fortuitous, but also an indication of the fact that we're also thinking along the same lines. So that meeting is due to be held in the next couple of weeks. Thank you, Chair.
Thank you for that update, and thank you for that work. I know it's slow at times, but sometimes you've got to let national policy catch up with where the rest of us are at. And the other working group is the Integrated Care Hub working group. There's a new officer lead on that, but I think there is a meeting scheduled for October at some stage. And as a result, there'll be something more to report on that. I know the business cases are being worked up for two integrated care hubs as part of the first wave, one in Stoke-on-Trent and one in Staffordshire. Okay, and so in terms of the other 2 recommendations, we're going to add in West Midlands Ambulance Service and the Community Mental Health to the full programme. Is there anything else that we want to raise in work programme? Keith.
Yeah, it was again with the ambulance service. In terms of, I realise that about reaction times, or rather times of people, the ambulances getting to where they need to go. There was another question which I did raise at a committee meeting with regard to the information that was given to people on the ground during an incident, or incidents, shall we say, there's about 3 of them now, I believe, whereby the information in relation to defibrillators and access to them, could you please raise that as a part of their remit for coming in, so that we don't get a blank face when they turn up and they can't answer any questions on that particular subject? Can you make sure that they are aware that in the Moorlands we've had at least 3 incidents where people unfortunately have passed away when for 2 or 3 minutes they couldn't get access to defibrillators, which was the whole point of having the defibrillators there in the first place.
So we've raised that already. The response, I propose, just in terms of time, it may be easier for me to respond on email to committee, whole of committee, unless you want to go through it now. But we've done that, and I was satisfied with the response because they had already investigated. Was it Ipstones?
Yes, it was Ipstones.
Yeah.
There's been other incidents other than that.
Let me respond on email, and then, albeit I am not responding, justifying West Midlands Ambulance Service. So I'll give you the answers to the questions I asked, and then hopefully that will answer your questions. If it doesn't, then come back with some additional ones.
I think if I may, Chair, it should have been an easy fix. Once the thing was raised, it's not an operational sort of wheels on the ground issue. It was a software issue within their card system, which didn't even seem to be linking up with the national database for defibs. because the person was stood next to it. They knew it where they were, but the operator couldn't hook it up with what the access code was, which is just, you know, jaw-droppingly bad. And it should have been a bit of an investigation and a bit of tweaking of the database, I would have thought. So hopefully whatever they've told you might have solved it.
That's not quite what they told me either.
We'll see what they say on the day.
Okay, so are you suggesting I just write a summary for committee and circulate it, and then we'll do the rest of that discussion in the 13th of November?
Well, I'm happy with that. My concern is that they'll come and answer one set of issues that they're almost certainly going to prepare for, and then they're not going to necessarily know about the defibrillator thing, and we'll be back to square one again when we give them the information and they haven't got a response back from us still. So it was just letting them know that this defibrillator issue they need to come with information to answer our questions on that day, because I don't want to go back another 5 or 6 months. Because if it happens again, God help the person that it happens to, you know.
We'll be writing a terms of reference for that meeting for what we would like the ambulance service to talk about. I suggest, given the strength of feeling, we'll just circulate that to committee in advance, so that if there is anything that members want to specifically pick up, they can do so. One of the difficulties with the ambulance service is they're commissioned by one authority, which is Dudley?
Sandwell, isn't it?
Sandwell. And so as a result, we should not be really scrutinising. The Commissioner of the Services should be scrutinising them. We've tried to persuade them to do so over a number of years, and we've resolutely failed, so, which is why we've gone down the route we've now gone down, which is we'll bring them in irrespective. But let's write those terms. Let's write those terms of reference. I'll send them round, and then if we can focus in the questioning on that would be helpful.
I think, Chair, if I may, the specific question that would satisfy me and probably Keith is what went wrong in Ipston's. If they can tell us what happened and why and what they've done to fix it, then hopefully they've fixed it for anybody else.
Yeah.
That was the question I asked them, and they didn't mention software integration. They mentioned... They mentioned something which related to the name of the equipment, name of the location being understood as two different things. One on the system saying where it was in Ipstones, and the other one being not quite where it should have been, which is why I then asked, well, surely you're using grid referencing and postcodes and what 3 words? Because actually what 3 words will take you within a square inch of a defibrillator.
Chair, it wasn't that the caller couldn't find the defib. The caller was stood next to the defib on a mobile phone.
It was them that couldn't give them the code.
The other point they made was on the same sort of issue was to try and encourage people to use cabinets so that they are publicly accessible rather than in buildings which you can't access, which I think is a fair comment in the generality, because there are also schools who are putting in defibrillators where you can't generally access them, and if you think, I think the stat I saw was 69% of people live within 8 minutes of a school. And so actually not being able to access a defibrillator, even though there is one, is also worth highlighting, but not the answer to the Ipsones problem, I accept. I'm going to draw a guillotine to that debate. I think we've got a plan, and I'm going to say thank you for your involvement this morning. I thought the mental health session was really useful, takes us a bit further forward, so thank you, have a good afternoon, and we will see you again in 4 weeks' time.